anything you want to buy for kids. Sleeping bags, bus tickets, I don't care.
Well, hello, friends, and welcome. I'm Kimber Gall. I'm the mayor, and I appreciate everybody being here. Just a few things I wanted to talk about. I'm really thankful that we're starting this mayor's initiative on mental health and community health. I think it's a really important issue that impacts all of us. And so having these conversations to better understand and maybe even to be better understood is going to be a real good thing for our community, I'm hopeful. And I'm hopeful that we'll continue this dialogue as we move forward through the months over the next several years. We will be having quarterly meetings with different topics. All kinds of topics. So if you have topics that you're interested in, you can always email us and let us know. We'd be happy to hear what those are and see how we can incorporate them. You know, how this all came about is that, you know, mental health affects all of us. And whether we have issues, whether we have family members that have issues, friends that have issues, or just impacts from folks who don't have the supports they need that impact our businesses or our community. So really wanting to just remind folks that the thing about mental health is that it doesn't discriminate. It doesn't care. It doesn't care if you live on a hill in a big house, have a great job, or if you live on the street or anywhere in between. It doesn't care. You know, it just impacts people in different levels. And with COVID, as we all know, there's been a lot of exacerbation with that. I work at Eureka High, my day job, and I've noticed a lot of that with our youth from being isolated and those kinds of things. And I really appreciate that we're all here to have this civil conversation, respectful dialogue. We really want to hear your frustrations as well, though, because that's how we can, we can't work on things until we can identify the problems that you yourself are experiencing or feeling like you need help with. This is a community problem. And it takes community-based solutions. So we're grateful that everybody's here and everybody on Zoom. So with that, I'll save my comments till the end, but I appreciate you. If you need to use the restroom, just go out this door and head to the right, up a little ways. There are tacos, there's coffee, there's water, and NAMI will be out tabling as well as the Hope Center for information. So again, we appreciate you being here, and I'm going to turn this over to Jacob Rosen.
Hey there, everyone. Thank you. My name is Jacob Rosen. I'm the managing mental health clinician for Crisis Alternative Response of Eureka, a new program under the City of Eureka banner for mental health. We're really excited to put this on. This is our first in a series, as the mayor is saying. We'll be doing this quarterly, and we'll hopefully be cycling topics. The email that she mentioned, if you want to send topic suggestions, is townhall@eurekaca.gov. And that's on the city website as well. So if afterwards you have comments or follow-up or any suggestions going forward, you're welcome to send it there. Before we get started, I have two quick announcements. First and foremost, I'd like to apologize to Leah Nagy for spelling her name wrong in our announcements. My apologies, Leah. We'll do better about screening that next time. The second one is I'd like to really acknowledge the kind of awkward space that we're going to have between the panel and the microphone. We wanted to use this room because we're able to use it to also stream Facebook Live, Zoom, and the city's website so that folks who aren't able to be here in person are still able to view it. But it unfortunately creates a situation where there are many walls between the panel and the person asking the question. So my apologies for that. That's certainly not our intent. And anything that we can do in the future, by all means, if you have suggestions, let us know. So the following guidelines have been created just to kind of create a structure for this. We want to make sure that this is a safe environment and that folks can come up and share what they've experienced and ask their questions in a manner where they feel supported. In order to do that, we kind of just have some ground rules to make sure that folks are comfortable in doing that. You may not agree with everything that everyone says that comes up here. You may not agree with the opinions that are said or the questions that are asked, but we just want to remind everyone that the folks who are here today are your fellow community members, and we want to make sure that they're treated with respect just as much as you would like to be treated with respect. The ways to ask questions here at the panel today, there's going to be two methods. So the first one, if you're feeling comfortable with coming up to the podium and asking the question of the panel at the microphone, you're welcome to do that. When we get to the point where we are sharing or doing the Q&A, we'll have folks line up on the left side of the room here, your right, and then we'll kind of have folks line up to do that. On the right side of the room, or your left, on the counter, there's a series of note cards and pens. And so you're welcome to write those questions down. You're welcome to remain anonymous, although if you would like us to read your name so that you know it's your question, you're welcome to put your name on the top left corner. And if you'd like to address a specific panel member on the note card, just put their name in the top right corner. Just want to make sure I cover everything. Yes. Yep. Everyone up here is the panel. We'll be going through introductions in just a minute. When you come up to the podium, please go ahead and give your first name so that if we have kind of a conversation, we can address you by your name. And, you know, we definitely want to invite you to share your experiences, but we also want to make sure that everyone has time to ask questions. And so, you know, if we end up cutting you off, it's not because we don't want to hear what you're saying. It's just that we want to make sure that everyone else has time as well. And we'd like to be able to help you find a question in what you're feeling too, so that we can also make this as educational as possible and folks can get, you know, information. If you have questions for a specific panelist when you come up to the front, go ahead and let us know. And lastly, if there is any sort of disrespectful commentary or anything like that, we may ask you to take a seat. If that continues, we may ask you to step out. Again, that's not because we're not wanting to hear what you're saying. We're also happy to engage with you outside. We just want to make sure that the other folks who are here and have taken the time to show up have time to ask those questions. Okay. Any questions from anyone? Just real quick on like procedure or process? You can raise your hand. Yeah. Yes, and so for folks who wanted to send a question ahead of time, they're able to email them, and then we've written those questions down, and we already have some note cards prepped. But otherwise, if you want to ask questions, you're welcome to come up and stand at the podium, or you can write one down on the note cards on the right there. Yeah. Yes. Yeah. Yep. Yeah. We will as we start the Q&A process, we'll start pitching those to the panel. Any other questions or anything about process? Yeah. If you'd like to make suggestions, you're welcome to come up and share those. And then also, if you'd like to turn that into a question, we can do that. And, you know, it may even just be a question of like, are those suggestions possible to be fulfilled? We do want to turn this into, again, trying to find like solutions and coming together as a community, right? I mean, I think as we can all identify there's gaps in the system, and we want to be able to work on those and come up with solutions to help everybody and support everybody. And so if you have those suggestions, by all means, share them. And then we can, you know, certainly discuss them if there's a question in there. Okay. Anything else? Oh, yeah. So for our folks that are joining us digitally, unfortunately, you won't be able to ask questions or participate today. The Zoom chat is turned off. We are recording, though, and so for anyone who isn't able to stay the whole time or who is watching digitally but has to leave, then it'll be made available later. Okay. All right. So without further ado, I'll introduce our panelists. We have Dr. Mark Lammers from Humboldt County Behavioral Health. And then we have Leah Nagy from NAMI, National Alliance for Mental Illness. We have Commander Leonard LaFrance from the Eureka Police Department, and we have Public Defender Luke Brownfield. I'll turn it over to whoever wants to jump into their presentations. We'll do a short introduction, and then we'll jump into the Q&A.
Yeah, just start, Mark. We'll go this way. Mark will start. Sounds good. Turn your microphone. Good.
I believe my mic is working. Can you all hear me? Very good. Hello, my name is Mark Lammers. I'm a clinical psychologist. I live in Eureka. My children have gone to school in Eureka. For a number of years, my wife had a business in Old Town, and I'm a big fan of Eureka. I think we have something really special here. I love the work I do at County Mental Health. I've worked there for about 15 years. I do a lot of work with the LPS conserved population. I provide coverage at the correctional facility, and often get called in for unusual circumstances or complex cases, in addition to working with law enforcement and the crisis negotiation team and a couple of other things like that. I want to say I'm really grateful to see all of you here. Travel, even within the neighborhood these days, can be challenging, so I'm guessing people all overcame other obstacles and put other things aside to be with us here today. And I appreciate it. I'm looking forward to hearing from all of you. And I'm going to pass it off to Leah.
Thank you, Mark. Can you guys all hear me? Alrighty. So my name's Leah Nagy, and I'm currently president of NAMI Humboldt. I have lived in Arcata 40 years. Where I live, the train used to come right by my house, and my youngest son would wave at the conductor every night. And I was actually drafted into the mental illness arena when one of my sons was diagnosed with serious mental illness, and I didn't know where Sempervirens was. I didn't want to know. I still remember the feeling I had when he was psychotic and got in my car, and I assumed it was drugs and hoped it was drugs. Turns out within 3 days, they diagnosed him with bipolar disorder. And that was my introduction to this whole new world of new language, it was overwhelming. So one thing I did was talk to a teacher. I was teaching at Redway at that time as a special education teacher, and I talked to another teacher at the high school whose son was going through the same thing that my son was, and spent hours on the phone with her. So over time, when I kind of recovered from all this trauma, I actually got involved with NAMI, and I ended up really starting to work with families because I remembered the feeling I had and I wanted to be helpful. So I started by volunteering in the Sempervirens parking lot, just showing people how it was confusing how to get in the door because you couldn't go in the front door. You had to go all the way around the building, go through the back door. Sometimes that gate was locked. And then Lance Morton, who was the mental health director, actually asked me to take a temporary position as a family liaison, which I have been doing for 25, 30 years. And so I'm so pleased you're here. I'm so happy to be talking about ways to get help and stigma, discrimination. And I agree with Kim, it's a community thing. It's not mental health against this NAMI or this against that, the police department. We're in it together, and I think this is a really good start on talking about working together to get the loved ones in our community some help. So, and I'll maybe have a chance later to talk about NAMI services. I don't want to take the time right now, but
if you'd like to talk about it right now, that'd
can
be
I
great,
just for a minute?
That'll give folks an idea.
Okay, I don't want to hog the time away from these guys, but here in Humboldt County, there are 3 different support groups, and anyone can come to them, any family member or caregiver who's worried about somebody. And we meet Mondays at 4:30 at Humboldt Plaza, and then we meet Thursdays at noon at Humboldt Plaza, and then I do a group in Redway at 3 o'clock at the Redway Family Resource Center. And my cell phone is all over the world. And I don't know if we have it printed anywhere, but it's, I'll give it to you guys later, but it's 707-845-3233. I take calls from families all the time. And so I want you to know that. And my email is just my name, leahnagy@yahoo.com. I don't use the county email. So I get emails as well, people asking for information. And if I don't have the answer, sometimes, like today, Mark answered a question for me, and I'll try and find out the answer for folks. NAMI also offers an 8-week class called Family to Family. Families can come and they leave with a binder, probably 2 or 3 inches thick. And that will be given again free in the spring or the fall. We do it usually once a year. And then the other couple more things I just want to add. We have a family advisory board, which is a board that makes recommendations to county mental health on what families need or want. And we meet every Tuesday from 12 to 1. Not every Tuesday. The second Tuesday of every month. I'm working myself too much here. Anyway, we meet at noon the second Tuesday. And again, you can email me for more information on that. And then the other thing I'd just like to plug is the existence of Waterfront Recovery Center for co-occurring or what they call dual diagnosis. 70% of folks on Sempervirence, I've been told, have mental illness and substance abuse. And so Waterfront is another really great resource. It's right next to Target. So if you need to know about that, hopefully Waterfront will be here for the next town hall or when we do one on substance abuse. So again, I want to thank you for being here. I hope I didn't talk too long. The teacher in me kind of comes out sometimes, but I'm going to control it and pass it to LaFrance.
All right, thanks. I'm notorious for having presentations on PowerPoint. I did not create a 10 or 30 slide PowerPoint, but I created a 2-slide. You're welcome, City Manager. It helps keep me on track so I don't get too out of whack. I'll see if I can control it from here. So, all right. So again, I'm Leonard LaFrance. I'm a newly promoted commander with the Eureka Police Department. I oversee investigations and special teams. Investigation includes our criminal investigations division, our unit, and also CSET. And once our POP team's back up, our POP team as well, and a bunch of other teams within that side of the house for Eureka Police Department. I have been with Eureka Police since 2007, so about 16 years. Back in 2018, the reason I'm really here is things kind of kicked off for me. I was asked to develop a team called that wasn't officially named yet to really address issues along the Waterfront Trail in an old town. That initial thought process bloomed into the Community Safety Engagement Team, or CSET. And the initial goal, again, was focusing on areas, and it really bloomed into focusing on bigger issues we'll talk about in a second. And I was developing that team and implemented it and then supervised it until about October of last year when I was assigned as an acting commander. I'm also part of the Humboldt County Crisis Intervention Team Steering Committee. Every year, the county does a 40-hour training for law enforcement and for mental health professionals to collaborate together. And so I'm on that steering committee to get a general idea of what the training will look like. Leah's also on it. We spent a couple days together last July in Pittsburgh. That was a good time. Leah's a lot of fun. I'm also a CIT instructor, so I teach various classes, including classes on autism. I teach classes on de-escalation. I teach de-escalation not only for law enforcement, but also for non-law enforcement personnel. And I've also taught with the regional center down last year at a 3-day seminar in Ukiah about autism and law enforcement interactions. I also helped develop a 50-50 or mental health hold training for law enforcement this last year, working with Jacob and some of our partners with DHHS to really push for law enforcement to divert as many people away from going on a mental health hold to other services versus going to a bed into the ER. And so we've had, from EPD standpoint, we've had great success with that. And I'm also a trained crisis negotiator. That really rolls into my duties with CSET. So just a real quick snapshot of just what we've been involved in with mental health in the community in the past 5 years. So again, CSET, really 3 primary focuses, but then a 4th, homelessness, mental health, or people in crisis calls, substance use disorder, and then trauma. Trauma is really you peel back the onion, that's really the core base of this. But one thing for CSET is the proactive engagement, going to the community, knowing our homeless by name, knowing a lot about them, knowing their families, trying to connect with them, getting streamlined to resources, cutting red tape out of the system. Mental health, CSET currently responds to about 40% of all mental health calls for the city of Eureka. So that's a giant portion of time. Those often take a lot of time for officers to engage those problems or those issues that are occurring, bring in more resources. And so we have a specialized team that focuses on that as well. But they handle right now about 40% of all mental health calls for the city, which is around 400 to 500 a year. Calls they handle. And right now we're on track for about 1,300 mental health calls for the year on a very, very short sample size. One thing, so within CSET, we have CSET here. We have Uplift Eureka, which is houses our outreach team, and a bunch of other services. And we also have CARE, which is Jacob's new team. So we call it the 3-pronged system. So you have law enforcement, mental health, and outreach. Within Uplift Eureka, we worked on the development of outreach workers. So Larry Alexander and Robert Williams, if you haven't met them before, they're phenomenal. They're commonly located down at Freemeal during the morning hours and lunchtime, then out and about in the community, helping us out, connecting with folks in services. But I was involved in the development of those positions as well, because we really wanted a non-law enforcement with our team, someone who wasn't a cop, but someone who could still do the work and connect with people, because we don't always need a cop. I was also involved in the development, implementation of Jacob's team. One of my baseline projects during grad school was working on different ways to build up CSET into a bigger program that it currently is, adding a mental health component, adding an outreach component, adding a physical health component as well. And so I think January of last year, we started a work group. And Jacob, you're hired in July 1st or August 1st? August 1st. So it's pretty cool to see that program where I put a lot of work into educational wise, and it actually came to an actual real project that's actually as a living person here with some other folks that are doing the work now. And we're still piloting that program, but it's looking very positive for us, adding that component to our teams. And then I work a lot with Providence and St. Joseph's Hospital. If you're not familiar, all mental health holds now go to the ERs instead of over to SV or Semper Virens. They go to the ERs, and so the past 3 years. I've been working very close with them on case management, de-escalation, training their staff, solving very odd problems sometimes with them. So we work very, very closely with them. I should say CSET does. I pretty much go to meetings all day now, but our CSET employees spend a lot of time with them. I also work a lot with behavioral health and with child welfare. On pretty much a daily basis, we're in communication with people from behavioral health, and we work closely with child welfare because we really want to go upstream and really connect with kids before they endure a ton of trauma and get them on the right path in the right direction. And then we work with a lot of community partners, so Betty Chin, Freemeal, Salvation Army, The Mission. I think there's like 50 plus partners we work with. We really call CSET social workers with guns. That's really what the kind of work they do. It's not perfect, but it's definitely needed, and it's really about balancing compassion and accountability in how we do things. And in the back, I'll call Sergeant Omi. He's the new sergeant for CSET, and then Officer Clark is back there somewhere. If she's standing, you won't see her. But she's our MIST officer, our mental health officer, and then Laura up front here is one of our non-sworn, community service officer who does a lot of case management for us, admin work, administrative assistant, and then we also have a non-sworn professional, a community service ranger, and we have a couple of vacant positions right now. But we can talk about this more, but that's all I got. So.
All right, I am Luke Brownfield. I am public defender here in Humboldt County. Born and raised here in Humboldt. Sure. I'm born and raised here in Humboldt. Been with the county for about 13 years, the last 7 of which at the public defender's office. Our office works with people with mental health. Pretty much the majority of our clients, criminal clients, are people who suffer from mental health issues. It's about 2 years ago, we were able to hire a social worker to work specifically with this population. That has had a tremendous effect on our clients as well as just the office in general. We are able to help people get the mental health treatment they need. They are able to get the drug treatment that they wouldn't have got without those social workers. We also have a satellite or sister office. Megan O'Connell, who's in the back of the room, runs that.
I can't hear you.
Okay.
There we go.
And Megan O'Connell was able to hire a social worker last year. So between the 2 offices, we have 2 social workers that pretty much exclusively work with people with mental health issues. I also, we do the conservatorship calendar, so we get to cross-examine Dr. Lammers pretty much multiple times a week. Kind of on the opposite side, but working together whenever we can. We also do the writs and reces that come out of Semper Virens, advocating for people who are in SV and either do not want to take their medication or would like to be released.
Thank you, panel. Just a couple pieces that I forgot actually before we kicked off to the introductions. I'd like to just mention that NAMI has a donations table out here with a bunch of resources. So if anyone's wanting to give monetary donations, please go ahead and do that. That really helps continue their programming. And then also, I'd like to mention that the Hope Center is also tabling. They have a table out there as well. Betty Garfield and one of the Cal Poly interns that they have are out there with a bunch of resources on mental health and kind of local stuff and how to get peer support and that sort of thing. So they're a really great program. They're actually on Behavioral Health's campus there at 720 Wood Street. They run a really, really good program. And then I'd also like to give a big shout out to Humboldt County Behavioral Health for partnering with us on getting a lot of this running. We're excited to continue collaborating with them with both this town hall series as well as other programming and joining together to help bolster the community resources. So thank you, DHHS. Okay. So I think at this point, we'll move into the Q&A section. I think to kick things off, just to kind of get a sample running, we have a written in question from ahead of time. And so I'll hand it over to Mayor Burgell to ask that question to the panel.
Thank you. So our first question is, what can the community do to get a mental health court in place? Do you think it is needed, and do you think it would help? Who would like to take that one?
I can take that one.
Thank you.
We are actually working. I've been discussing with the courts about getting a mental health court. They seem to be a little bit resistant to it initially, but I think, the more outreach we can get, the more support for a mental health court, I think it's needed. Mental health diversion has become, it's newer for the courts, but we are utilizing it on as many cases as we possibly can. And the success we've seen on some of these cases, people who would have been spending years and years in prison, able to divert their case through mental health diversion. We've seen it work. It's a little unfortunate right now. There's not enough services for enough people, or for the amount of people that would be able to utilize them. So the court is a little bit hesitant because we just don't have enough providers to get people the help that they need. But if we could get the court up and running, I think the judges, while being resistant, know that eventually it's coming. But yes, we'll get there, and it'll work.
Leah?
So I don't know how many people remember, but we had what we called a STAR court with County Mental Health, and it was a grant, and it was very successful. It was like a mental health court, and people, came back and talked to the judge and stuff. But that was a grant that ran out, and we were all disappointed when it did run out because it was very successful for folks. So I just wanted to add that.
Dr. Lammers?
If I could add just a little bit more. I noticed today on the Times Standard that there's a headline, forcing mental health treatment could get easier. There are statewide trends now going on for counties to come in line with assisted outpatient treatment programs, things of that nature, which essentially are a collaboration between the courts and mental health. One of the challenges that mental health often has really had with trying to provide services to people who everybody recognizes need more help is that treatment is voluntary up until certain criteria are met. And with the involvement of the courts, who can come in and say, we've got some leverage on this other issue. Would you rather access voluntary services, or would you rather do time in jail or prison? Unfortunately, it's not a great reflection on us as a culture that that's the option that we sometimes give people. But at the same time, it encourages folks to see the benefit that they would get from accessing treatment voluntarily. So collaborating with the courts for providing mental health treatment is really a necessary step forward. It has to be a careful balance between people's civil rights and their right to self-determine and, all those kind of things. But certainly as a community working together on these options, we have better outcomes than each person trying to do it alone.
360 degree options, we need them. There's not a one-size-fits-all. These many issues we have, they're very complex. People are very complex. When you start peeling back, there's a lot of things going on. So we need every option on the table. Again, the issue we have is, again, how do you fund these services? How do you staff these services? But there's so much overlap between mental health, And again, there's overlap with mental health, homelessness, addiction. There's a lot of all this overlapping, but there's so much overlap in the court system also that you need that balance of a place they can go. And we can do with compassion and accountability. So we're going to try to help you, but also your behavior is unacceptable. But we want to help you get to a better spot to stop the behavior.
Thank you. All right, we'll do a couple folks coming up to the podium here next. And again, just a reminder, if anyone does have questions that they want to ask, they can come up to the my left, your right side of the room, and then we'll go one by one. So, sir, if you want to come up and say your name and going to talk about what you're wondering.
My name is Charles Endage. My girlfriend's been dealing with mental health for the past 7 years. We've been together. How many minutes do I have to talk?
There's no time limit, and so if you have a little bit of lead in, by all means, go ahead and
I
tell
have
us
a
about
bunch
that.
of questions about case managers. Yeah.
Yeah, we'll probably do one, maybe two questions, then we'll cycle back. But if you want to then
Well,
come
then
back,
I don't need to be heard then because I'm not asking questions. I'm trying to have things changed.
Yeah.
And what was told to me, and now they're keeping my girlfriend away from me. Like, no, thank you though.
Well, Charles,
No, it's the
we
same
want to hear what
thing.
you have to say.
No,
So go ahead
it's
and
just like court. Court, they ask you the questions, but you can't rebuttal. You have to give a straight answer. So if you don't have the time to listen to me, to what I have to say about my girlfriend and about the shit I've been through, then I don't need to be here.
There's no time limit, Charles. You're welcome to share your part.
No, never mind.
We got time.
Okay. So this is the way it began. My girlfriend gets locked up, gets put in Napa. She's pregnant with my kid. I didn't know. CPS didn't get a hold of me till a week before the adoption came up. Okay? So anyways, I lose the kid. I'm still with my girlfriend. She's out in public with me, going to music festivals. Like, fine. We see a case manager. We say hi to her. And then the show's over. We're leaving. And a lady stops her and says, "Oh, we can help you." And then another case manager, I'm living, me and my girlfriend living with a friend. "Oh, they need to get out of your house because they're tweakers." This lady doesn't even know me. That's the issue. None of yous, live with the person. None of yous know. You're not, case managers are, and this is true, ex-drug addicts, not all of them, ex-drug addicts, alcoholics, had sexual crime to them, and they're not degreed in anything. And they're telling my girlfriend, "Oh, you don't have to take your meds if you don't want to." When you tell that to somebody, they will refuse to take their fucking meds. And then when they feel a mental patient, when they feel better and they start hearing that, they think they're better, but they're not. And so then they stop taking them because it's their right. It's their right not to take them, but then when you throw them in the mental institution and strap them down and force them, that's not right. Okay? It's and then conservatorship 100% is bullshit. I don't beat my girlfriend, which conservatorship says, "Oh, I'm violent." I don't have a violent thing on my record. The cops have been to my house 30 times in 1 month, and there was never a bruise. Shit really needs to change. She has a perfect home under her head, full fridge, well taken care of. And then when she gets off her meds, it's super hard to, deal with, but I deal with it. Shit's got to change. Your laws, your rules, never did I lay a hand on her? And now they locked her up and like keeping her away from me. It's bullshit.
It's a really difficult situation, Charles, and I want to thank you for sharing, because it takes a lot of courage to come up here and talk about that.
There's a whole shitload more, which I don't want to take up other people's times. But I'm telling you that it's.
So, Charles, I'm hearing kind of three pieces here. One, I'm hearing
I got
a need for more family support and clarity and kind of transparency on how the system works.
And find out the real truth and facts, not when you're not on your meds. Is it legal to ask some questions and literally listen to, he beats me when she's just mad that she's in there? When I leave visitation, she's distraught. She's been with me 7 years and she wants to go home. Why do you think she's distraught?
So I wonder if maybe we can pitch to our panel both maybe some clarity around the
I don't know. I don't have
component.
the answers for you. That's why I'm here.
No, and I'm saying to our panel can maybe talk about how medications work voluntarily and involuntarily, as well as maybe how to get families more support, maybe through NAMI or some of the other surrounding kind of support networks with the Hope Center.
Yeah.
Would that information, is that the kind of information that you're hoping to hear right now?
No, it's not information. Things need to change. Her mom's mentally ill. Her mom's in jail right now. So by conservatorship locking her up and not, it's not healthy for mentally ill to be with mentally ill. They pick up traits. I mean, I'm not a psychologist. I just see what's going on and I see what's happening. I'm not blind.
Well, thank you, Charles, for sharing. We really do appreciate that.
Yeah, that's not even.
It's a drop in the bucket. I hear you.
It's not even that.
I hear you on that.
And there's a hole in the bottom of the bucket.
Unfortunately for all too many families. Thank you, Charles. Panel, Mark, would you like to?
Can I just reflect on recognizing the true difficulties that people who have a family member that's conserved face across the spectrum, that we recognize that folks that go to that level of care are demonstrating to the standard in court of beyond a reasonable doubt that they're not able to provide for their safety, and that it's a condition as a result of a mental illness. And so the court steps in and says, we need to take this person and put them in a secure environment, stabilize them, with the intention being not to keep them at that level of care, but to allow them to stabilize and progress and to get to a point where they're returned to the community. In Humboldt County, we have something on the number of 150 people who are under LPS conservatorship, which for a county of our size is really significant. I was talking with Leah earlier where she said in Shasta County, for example, they don't conserve anybody. So there's always a tension between the desire of family members to be in contact and relationship and immediate contact with family members, and at the same time, family members often really advocating for people, for folks to go to that higher level of care and be conserved. But they're pretty well-defined guidelines within the Welfare and Institution Code, Lanterman-Petrus Short Code 5100, and the rest that specify when somebody gets conserved. And it's typically done for the safety of that individual. But man, we recognize it's a fraught thing all the way around. People who are LPS conserved typically don't want to get voluntary services. So that's what causes the county to move in that direction. But I really appreciate the feedback from this gentleman, and know that it's painful for folks. This is a real issue.
So I think hearing Charles, it really brings home the pain that families go through. And I think it's important to talk about it. It's important to talk to people about it. It's important, and I won't word it exactly what he said, but things do have to change. And I think the more stories you hear and the more things that happen, it brings us together maybe in a unified way to help things change. But I just wanted to say that much.
Thank you, Leah. Does the panel have any comments on the voluntary versus involuntary medication component or the benefits of med adherence?
How much time you got? You know, there's a phrase that we use in clinical psychology and mental health treatment called anosognosia, which means recognition of having a mental illness. And one of the first things that often goes when people have a serious mental illness is the ability to recognize that they're no longer coloring within the lines. They're no longer doing the same things that everybody else does, and that their behavior has become disorganized and even frightening to other people. And with that anosognosia comes the lack of understanding that psychiatric medication can help stabilize that condition. Additionally, folks with mental illness often feel normal. It might be hard for us to recognize that, but they feel like their behavior is meaningful and purposeful, just like you and I do. And when they take psychiatric medications, they're very aware of the side effects of medication, and they feel like it's changing them in ways that they don't like. And so makes it very challenging for folks with certain kinds of mental illness especially to feel the benefit of medication. And when it gets to the point where they're a danger to themselves, if they're hearing voices that are telling them to kill themselves, for example, or if they're a danger to others because their behavior is so disorganized or threatening, or if they're so gravely disabled that they're unable to dress themselves, feed themselves, and it's imminently dangerous that something bad is going to happen, so they're gravely disabled. Under the laws of our state, they need to take medication voluntarily. So even somebody in that condition, if we take them and psychiatrically hospitalize them, we can put them in the hospital for 72 hours and stabilize them. Perhaps they're doing better. But once they're released from the hospital, the question of taking medication again becomes one of voluntary. So this is a constant back and forth. Even in the correctional facility, in the jail, we often start people on medication when they come into jail. They seem to be doing a lot better. They get out and they stop. So lack of access to resources for folks, and that question of recognizing the benefit from meds makes it hard for people. So this is an ongoing issue with mental health treatment in our community.
So I think with families, the biggest obstacle is the lack of insight. There's a book called I'm Not Sick and I Don't Need Help by Amador Xavier. And I will say that it is hard to see your loved one taken involuntarily to be treated, but it has saved my son's life over and over again. He would walk in front of a truck. He might drive recklessly. I mean, it's a whole battle of, it's the person's journey. So the person with the mental health challenges has to figure out, is it worth taking medicine to keep me safe, my family safe? It's their decision. And we as family members, we can't, force medication on people, but we do, just from my lived experience, really appreciate it when I get help from Arcata or the sheriff, whatever, and get my son involuntarily treated to get him stable. And but it's an ongoing issue for sure.
Thank you. Charles, thank you again for sharing. Oh, okay. Next question. You want to come on up and say your name?
My name's Carmen Gentile. I'm just an ordinary citizen. And I wanted to ask questions about the talk given by the officer, LaFrance. The font on the slides are really small, and I couldn't make it out. And you're talking about something called CSET, an acronym for something. Can you clarify what that is?
Yeah, so sorry about the font. It's always a challenge making sure it's big enough. CSET is the Community Safety Engagement Team.
Community Safety. Oh, CSET. Okay.
Yep, CSET, yeah. Community Safety Engagement Team.
So when I see somebody sleeping in a doorway or on a sidewalk, I keep thinking there needs to be some kind of a squad I can call on my phone who aren't the police, who have street level expertise on responding to someone who's so destitute they're sleeping on a sidewalk. Is there such a thing? Is there such an entity that I can just call?
So currently, right now, within the city of Eureka, we have. So normally, if we have an issue like at a business with someone sleeping in a doorway, the normal businesses will be calling the standard 441-4044 into dispatch. That usually gets sent out to patrol. But if CSET is on duty that day, which they will eventually have 7-day coverage again. They would likely jump that call to handle. And what we're looking for in the future is with Jacob's team with CARE, is that eventually some of these calls will be diverted away from a law enforcement response to a case manager's response or a clinician response.
So is that something I could look up on the internet, CSET, and then a number that I would call street level?
Yeah, so CSET is a team. It's a law enforcement team within the city of Eureka or within Eureka Police Department. If you Googled it, you'll see we have a web page on the city webpage or the city website. But it'd be the same number, the 707-441-4044, because currently they're at 6% staffing level, I believe, for that team. And when they're fully operational, they're much more readily available to respond. But they're also heavily engaged in proactive outreach, doing some case management, follow up with a lot of folks. They're at St. Joe's quite a bit, working at Semper Virens quite a bit with some of the staff there and clients. The best way to access currently is the 441-4044. But
Thank
again,
you.
Thank you. Next question.
Yeah, my name is Steve Parr. I'm well known for being a thorn in the side of many people. Anyway, like our first speaker, I could go on for hours, but I promised the next speaker I'd keep it short. The thing about the involuntary, what do you call it? Anyways, when someone is conservatorship versus the 5150 designation, under which they are supposedly supposed to be put under 72-hour evaluation. I just want to get over this quickly, but in my experience, which there's been considerable amount of it, considering I have a couple family members who are badly in need of mental health support. I have one family member who's been to Semper Virens more time than I can remember in the last 10 years, 12 years, under a 5150 designation, and she has never been held longer than 21 hours. She's been out at as few as 2 hours. And I thought there was some kind of a 72-hour minimum evaluation they were supposed to go through. She has been taken to Semper Virens because of violent acts against other people with knives and whatnot, to where there was an obvious danger. And the way we found out that she was out again was she showed up back on the doorstep after going straight to her Connect and getting more drugs and then coming back over to the house still in a rage. And we called Semper Virens, and they told us that due to the privacy laws, they couldn't let us know that they had released her. And so that's an issue that I have direct experience with that absolutely needs to be resolved. I don't care if it's a state law, a federal law, whatever, but when someone is taken to a mental health facility after threatening someone's life, and then they are not held for the prescribed amount of time, that person that was threatened needs to be made aware of their release. It just seems like a common sense thing to do. And I guess that kind of ties into my next question for Luke. You said that this program that with the excuse me. Well, no, the program where the homeless court, whatever. And you said that you've had great success with diverting a number of people from prison who would have normally done years. And you said you've seen it work. My question is, how long are these people tracked? And what is the definition of work? Do you mean that it worked to keep them out of prison, or did it work to keep them community safe?
I would say both. It's worked for both. I've had clients that, because they've gotten mental health diversion, they get the treatment that they need, they get the medications, they get the services, and typically it's a 2-year program. They come back about once a month in the beginning, and then if they're doing well, it would be a little bit longer period of time, so maybe 3-month checkups, and as long as they continue to do the things that are required by their mental health providers that they've recommended to the court, then eventually after the 2 years, if they haven't picked up any new crimes, if they've completely done the program, their case would be dismissed. And getting that person to a stable position where they're not committing crimes in the community while getting the mental health treatment that they need, I believe is much better than having them serve 2-3 years prison.
Okay,
come
well,
back.
beliefs are great, but what kind of statistics do you have on that? What has been your success rate? What percentage of the people that go into that program not only stay out of trouble for the 2 years, because generally it's pretty easy to stay out of trouble when you're having to check in and you have all this support, but beyond that, I mean, that's what I consider to be a success rate, is the people that go from the program and continue to do well. That would be a success rate.
We've only been doing mental health diversions for the last 2.5 years or so, so it's hard to long-term affect. But just from the cases that I've done personally, I've seen people that have been habitual offenders completely turn their life around, work through the program, and not come back through the court system. So as long as we can reach some of those people.
Well, that's all noble and admirable, but
well, that's
but what about the people that would have been in prison and are out on the program instead and commit further crimes? That's, those, the people that are victims of those crimes don't feel any better about it because someone else in that program went on to do well when they've been impacted. I've been bear maced outside my back gate by a person who should have been in prison. When I caught him stealing stuff off my property, and he bear maced me right in the face. He was a felon on parole with felony warrants out for him, and he had just committed a new felony, and he was booked and released before my eyes stopped burning. Mm-hmm. And he you have some people that do well, but how many other people have been impacted by people that should have been in prison being out on the street committing crimes?
I'll jump in here too. I do want to highlight that not everybody who goes and commits a crime has mental health issues, and not everybody who has mental health issues goes and commits a crime.
But if you try to separate it all out, the homeless, the drug addiction, the crime, the mental health, are all, you have to realize it's all pretty well intertwined. There are cases that are strictly mental health. There are cases that are strictly drug addiction, cases that are strictly homelessness, cases that are strictly criminal. But the bottom line, the reality of it is that it's all closely intertwined. Certainly.
I just want to make sure that we highlight that, especially for the audience.
The reason I gave the example of my case with the guy with the bear mace, he obviously had mental health issues.
Okay.
And he should have been in prison. But anyway, so that's the thing, is that it's all well and good to divert people from prison. I'm no fan of prison, but at the same time, if you can't say, okay, well, these guys went on to become stalwart community members, but at the same time, you've had other people commit horrific crimes that they wouldn't have committed had they been in jail. You have to look at the whole thing and decide which is worth it. Is it worth it to have criminals used in the community just to save a couple people?
Thank you, Stephen. I think Mark.
Can I reflect? Thank you. I appreciate your comments, and I want to let you know that I share your experience, having seen many people that have been put on 5150 holds who've been sent to mental health with the expectation that they'd be there for 72 hours, and they are turned around in a much shorter time. The law allows 72 hours for that initial evaluation, but that initial evaluation can take place over the first couple of hours, and if it's determined for whatever reason that person doesn't need acute psychiatric hospitalization, they can get released. And there are any number of people who have had many admissions or 5150s that have not resulted in longer-term stabilization. And often the challenge of having substance abuse involved with that is that if it's considered that their issues are primarily substance-related, they may not meet acute criteria for hospitalization. At the same time, I also want to say we're kind of the leading edge of things that come down from the state level, both from the correctional judicial side and the mental health side. The state is under consent decrees to decrease populations in the prisons, that there are any number of initiatives to reduce the criminalization of certain kinds of offenses. And what that ends up doing is leaving the local community holding the bag for those individuals. So
Right, yeah.
it's a multi-pronged problem. Things we're trying to do now, at least, is to work collaboratively in the community with those folks to try and find solutions. And I appreciate hearing that you're having circumstances where you don't see those solutions working. We are trying to do things that we can.
Yeah, like I say, the one issue. I understand that for whatever reason they're not held for the full amount of time. I guess the main issue I had with that was the fact that the person that was in danger,
Right,
that caused the entire thing,
Right.
is put back in danger again with no notification. That
And
just to me seems crazy.
if somebody, like, we're all mandated reporters, and there's laws concerning what we can and can't disclose. HIPAA is this thing that everybody hears about, where this information is essentially super, super private. We're not supposed to disclose anything, even if somebody's had access to services. But if we are ever aware of somebody making a threat, we're mandated under these rules called Tarasoff to notify people. So there's some circumstances where we can relay that information, and other circumstances where we can't. And I really appreciate hearing your frustration with it. And I'm not saying it's a perfect system.
Yeah. Okay. Thank you.
Thank you, Stephen.
So this is something I've shared with the NAMI group, but I'd like to share it with a larger group, and particularly with the clinical psychologist. And that is a recent.
Just real quick, can you give your name and then also
my
make sure
name
you're
and
into the mic
location.
too.
Yeah, my name is Jeffrey Harris. I'm from Sacramento, California. I recently moved up to Eureka, California, going on 2 years ago. Okay.
Thank you, Jeffrey. And then just make sure the mic, if you need to adjust it.
Okay, this is working? Are we
No,
good?
you are. Yep,
Okay.
you're good. Thank you.
All right. So I will give the title, Similarity Between Schizophrenia and Dementia, Discovered for the First Time, Neuroscience, August 4th, 2022. And let's see here. Okay, so this is frontotemporal disease. That's where personality, social behavior, and empathy are controlled in these regions of the brain. Okay, so frontotemporal dementia, especially the behavioral variant, is difficult to recognize in early stages because it's often confused with schizophrenia. Okay, so they did some analysis, particularly with imaging, and the results published in the journal JAMA Psychiatry was that 41% of schizophrenia patients met the classified criteria for behavioral variant frontotemporal dementia. What that means in that 2 out of 5 cases, the potential for recovery is not particularly good. For example, here's an anecdote. I just wanted to know why my 23-year-old patient with onset symptoms of schizophrenia, such as hallucinations, delusions, and cognitive deficits, had not improved at all, even after 2 years, while another who started out just as bad was continuing his education, found a girlfriend. Okay, here we say research team felt the higher the patient's score, the more likely they were to have the expression, the phenotype, and the less likely they would improve over 2 years. And there's a loss of neurons there. Okay, so the upshot is that there's a subpopulation of people with schizophrenia who have a degenerative chronic disease, which is very much like a dementia of the advanced senior years. Okay, that's something I'm hoping he'll address. This is something that a lot of people don't know about yet. And then the other thing from personal experience, I've had a couple of people staying with me who have had issues. One had a borderline personality disorder, and he acknowledged that he did a suicide attempt by hanging some weeks ago. My reaction was to get him out of the house. I do not want someone like that around because things can go wrong. I don't want to get involved in that. And then I'm going to name this second person, well-known meth psycho, Patrick Wayne Button, who's staying with me close to 3 months.
So, Jeffrey, I just want to reframe it back into respecting our community members, right? I mean, even if there's something that is
okay, well, I got the
upsetting
name out.
to you.
I'm willing to violate that.
I just want to refrain from the stigmatizing language. But I think if we come back to the, I guess, differentiation between psychosis and dementia, Mark, do you have any comment on that?
That is a super interesting subject in lots of ways. And one of the things that distinguishes typically frontotemporal dementia or other forms of dementia and the onset of schizophrenia is that they happen at different life stages. Typically, dementia typically has an onset age 65 and after. Schizophrenia typically has an onset 19, 20, thereabouts. There are a lot of similarities. Schizophrenia tends to be a really significantly catastrophic brain disease. There's a biological basis to it. There's tremendous changes to the brain, in the temporal and the parietal lobes of the brain. Similar to what happens in dementia. Interestingly, dementia is characterized as a medical illness versus a psychiatric illness. Psychiatrists tend to not treat folks with dementia. There is some overlap, and in our community, there's a further problem that substance use, particularly methamphetamine use, and use of inhalants, huffing, a big problem here, whippets, gasoline, things of that nature, also cause changes to the brain that present as psychotic illness. And it's a medical condition that can't be psychiatrically treated, even though folks like that sometimes end up with psychiatric diagnoses and even treated with psychiatric medication. It tends to not really resolve, especially the behavioral problems that come with those kind of medical conditions. So that's like a little thumbnail sketch. Folks in the admitting process of the psychiatric hospital, things like that, tend to be aware of those distinctions. And currently, since COVID, there's been all the folks that get put on 5150s get medically cleared at local emergency rooms, which is a whole nother issue that maybe is going to come up at one of these. It's a real backlog in our system. But we try and tend to differentiate those kind of diagnoses to make sure that people get the appropriate kind of care. It's not appropriate really to put somebody with dementia in a psychiatric hospital. It's not really appropriate to keep somebody with psychotic illness in a medical hospital. So we try and address those issues as far upstream as possible.
Thank you. Next question.
Hi, my name is Dottie Russell, and I've gotten a number of telephone calls from a number of people that work for the county and live in the county, saying what a terrible tragedy it is that my nephew, Peter Rolsey, Leah, you know him, we went to NAMI together to try to get some help many years ago. Anyway, he passed away on the school bus stop a couple days ago. I think, Mark, you know him too. So it was a death that could have been avoided and should have been avoided. And now we can't bring him back. But we can make sure that the same things that happened to him don't happen again. It can't happen again. We need to look through this and evaluate. A lot of comments are made about the 5150 and call for a 5150 if somebody, is concerned about somebody. I've worked in advocacy for over 20 years in Humboldt County, and before that in Los Angeles, and I had the great pleasure of working with Leah, teaching school together at WIAT. So we've gone through it together with a number of people. And I think that there needs to be something done about when something's not going right. If somebody is housed and they can't be housed anymore because they don't keep it clean, then having in-home supportive services come in, even if it's in a rehab location, is necessary. That wasn't done. He lost his housing. Multiple things happened. Another thing that's really important for us to acknowledge is that if, quote unquote, the regular society doesn't accept somebody that has some differences, that they need to find a support system too. We all need a support system someplace. And if they don't get a support system in their regular community, their families, whatever, then they find a support system someplace else, and most often it's drug use. And so we can do better. We can do way better. And how that's going to work, I don't know, but I'd like to be a part of it. He went to the shelter that night that he passed away. And for some reason, he didn't stay. Nobody knows why. Somebody knows why. And we need to know why, because it'll happen again to somebody else. And that's wrong. We need to do way better than that. These people should not be dying. It's not fair. So I've been working with a number of people. And what about the people that knew Peter? What about those people? Is anybody doing grief counseling for them? Peter was the type of guy that he'd get his Social Security check, and then he'd hand it out to people. I was a payee for him for a while because he'd cash his check and then hand it out to people that he thought needed the money more than he did. And then he was hungry, and then he was homeless, and things just went down. He stayed at a rehab, some kind of place, and he said, I can't tell you what's going on there, but I'm at risk. They're going to kill me. And it wasn't because he was making it up. He went on to say these people are court-ordered or offered to be in a rehab instead of going to jail, and they're there, and in the house, they're dealing very bad drugs. And if I tell you, they will kill you and they will kill me. I can't stay there. So these kinds of things are happening, and some of the landlords know, some of them don't. Some of them don't know what to do. But the bottom line is we can do better, and we can review who's court-ordered or ask if they want to be in a rehab instead, and make sure that the dynamics, the social dynamics of the place that they're in is working. And you can tell by somebody's body language if they're scared to death or they're not. You can tell by the body language of how people are working together. That wasn't me. And then this whole thing about, there's not housing, and send everybody from Southern Humboldt up to Eureka, and all of that. I mean, for over 20 years, we've been told by lots of people, including people that have lived on our property for a year without paying any rent with no help from the county, that are saying, oh no, they just said that I have to go up to Eureka, or I have to go north. So there's so many things that we need to really review. The other day, I worked with a different person that had some mental health issues, and she had been breaking into cars and sleeping in the cars because she didn't have housing. She had already been arrested for assaulting her boyfriend. The boyfriend does drugs right in front of you, will take gases and breathe them, and he was arrested before that for abusing her. There wasn't any follow-up. There wasn't any follow-up as what was going on. In this particular case, I knew the family. They were from a different country. They called the consul. This has been over 2 years working on trying to keep this person safe. And this person that was at risk actually got mad and broke a window, got mad and tried to hit this guy who had been abusing her, locked her in the house and wouldn't let her leave for days. And nobody did anything about it. It was like, well, she's crazy, and so we won't do anything about it. This lady, when trying to be arrested, was banging her head on the glass, but she wasn't a 5150. This lady punched an officer in the face. She went to jail and was released the next morning. I called and said, can you talk to mental health? Can you do a mental health assessment? Clearly, this is not normal, regular behavior. And what's happening? The other day, she called me, and fortunately, she had my phone number, and she said, can you come and pick me up? And I'm like, where are you? And she said, in Washington. I said, Washington, where? And she said, the state of Washington. I'm calling from the ER room. And I said, I can't come pick you up. What are you doing there? And she said, I don't have any idea how I got there. And she was crying, and she's like, I just want to go back to my country. I don't know, whatever. And so the lady that was doing the intake there said, what's going on? yeah, I mean, she just wanted to use my phone. And I said, well, don't let her leave, because it's not safe to let this lady leave. She doesn't know how she got there. Fortunately, APS was already involved because I had called APS already. Fortunately, we had found her lost passport, so we had her passport. Fortunately, the animal control person knew who the dog was and knew how to reach me. We got the dog. So this is like a huge, huge big deal that for years she got by with behavior that she didn't know she was doing, that she didn't have control over. It's only by the grace of God that she's going to be picked up this week coming up, and she's living, even though the people that she broke into their cars to sleep at night in front of me yelled at this person and said, I know you're the one that broke into my car. You messed with the wrong person. We're going to take you out. We're going to lose your body, and you will be a missing person, and they will never find you. And that's what she was saying in Southern Humboldt. So that's a grave danger to somebody. We have to be able to pick up and do something and work together when somebody, I mean, she needed to be sheltered. She needed to be in a safe place that would keep her from being murdered. And in light of trying to avoid putting somebody in jail, it wasn't about putting somebody in jail. Sometimes it's about having somebody befriend someone and kind of follow them. If she hadn't have had our phone number, what would have happened to her? She would have been released, and if she came back, she would have been killed. And if she didn't come back, she might have got run over by a car. Might have been what happened to my nephew.
Dottie, thank you so much for sharing, and I want to express my condolences for Peter. It's a really tragic situation, and I appreciate the strength you show in coming and talking to us about it and advocating on his behalf. Thank you. Does anyone Mark?
And Dottie, I want to echo what Jacob has said. I knew Peter for a long, long time, and I feel your grief. I do, and what happens to so many families. And if I can just say one thing, that our system is not perfect at all. And I myself personally, when I come to work, when I think of folks in situations like this, my goal is to do better.
I just want to say you're magnificent. Really, seriously, it's because of you that he lived this long, and I appreciate it. And the Hope Center, too. I've been advocating for over 10 years for a Hope Center in Southern Humboldt. We need it. You're incredible. And
he had a lot of folks that cared about him.
Yeah, thank you.
Thank you, Dottie. Come on up.
Hi. Thanks for having me. My name's Celso Carrero. I'm a lifetime resident of California. I'm a carpenter. I've built some, like Larry Ellison's house. I've built some really nice homes. I'm a good carpenter. I also suffer from mental health issues. And there's some of us that aren't criminals. And I know, Doc, you mentioned that that there is modes like voluntary treatment. I'd really like to know what they are. Because I've called every place. I've called Open Door for references, for therapy, for everything. I've exhausted all the avenues. And, you know, I got to mention, for the past 2 years, I've been in Alaska doing remote building for people with a lot of money. And the crew that I was with, I've been working with a bunch of ex-vets that they have PTSD. So it's not from a lack of me trying to get better. Because I've been trying to get better, I've surrounded myself in circles of people that are trying to get better as well. And we, have like come to like a conclusion that we avoid like Western medicine. Like I just got to tell you, like my experience, and I'll try to be as quick as possible. I was diagnosed in 2017 by Will Kabat-Zinn, the son of John Kabat-Zinn, grandson to Howard Zinn, and the guy knows what he's doing. But he wasn't the first guy. Now, I've seen a bunch of therapists and psychiatrists, and every single one of them I got to, like at first I was diagnosed with bipolar, attention deficit disorder, dissociation. I was given just myriads of medications. And it wasn't until Zinn said, you know what, look, all those people, they weren't wrong, but they aren't right. And so my issues have been like finding the right treatment, like to deal with this, you know, because it just doesn't seem to be out there. The therapists that I do go to are all, and this is like, I had a psychiatrist, her name's Dr. Linnell Tyler from Truckee Tahoe Forest, who I was seeing right before the pandemic. And she was getting ready to retire. And before she took me on, she told me that. And when the pandemic hit, everything was kind of falling apart. And she said, look, you're going to need to find a therapist that is trauma informed. Well, what does that mean? I thought all therapists are trauma informed. No, they're not. They read a book and think they're trauma informed. And then you spend years and years and years going down these wrong roads. And, you know, I just want to like see if anything's getting changed in that direction, or, you know, because I could tell you right now, like I've taken years of tons of medications. I've been off all my SSRIs for 2 years, and I've been following the instructions of these guys. And like when I wake, I don't experience life like you guys do. I don't wake up in the morning like, what am I going to do with my day? I wake up and it's in survival mode, and I got to talk myself, you know, and then get back into the groove. And these are my issues to overcome, you know. And I'm trying to figure out where do I go? Like,
can I reflect back to you?
Yeah.
How much you are preaching to the choir right now. That the issues that you're reporting to me are really well known. Are
they?
Yes. Well,
to who?
But there's a chronic shortage of providers at every level in the state of California, not just the county of Humboldt. And then additionally, the appropriate level of care for individual issues, and this issue that you raise of being trauma informed or not. When a person goes to see a psychiatrist, the psychiatrist treats them by providing them medication. Medication is not always the end all and be all for all folks. Every bit of research that's ever been done on it shows that even when people are seeing a psychiatrist, they do better if they've got a therapist as well. So working in conjunction. And at the same time, what really matters is that you're getting really good therapy, that you're getting therapy from people that really have the training and experience and depth.
So who are these people?
Well, you know, the county is mandated to provide services to people with severe persisting mental illnesses. The county system itself is intended, all the laws that put together the whole system throughout the state is based upon this old state hospital system where people used to go and they used to get locked up. And you go to the state hospital and you might stay there your whole life. They took that system apart in the 1960s, early 1970s, and dispersed them back to their counties. And the way it's technically supposed to work is the county deals with the most severely mentally ill folks, and community providers are supposed to provide those next levels of support for people that don't need acute hospitalization, that don't have a diagnosis, for example, of schizophrenia, or, you know, there's a lot of folks with bipolar that don't meet that don't go up to that level. Our community is supposed to be able to provide the services that you're looking for. Are they able to all the time? They are not. And I've talked to people who have looked at a community level for a psychiatrist, for example, in Humboldt for multiple years and have not been able to find a provider. So do I have an answer to that? I don't have an answer to that.
Wow.
I may jump in with just a quick suggestion. I don't know if you've heard of the organization North Coast Association for Mental Health Professionals.
Not yet.
So NCAMP for short, NCAHMP, or MHP. My apologies.
And here's, I'm sorry, finish.
No, I was just going to say, as far as the ability to look for a therapist in the community, that association works with kind of bringing all the local therapists together who have a private practice and then post their information.
Website.
It has a really nice mental health directory of different providers, and it will show what their specializations are and what they've trained in. And so that, I don't know if that's necessarily answering the question, but as far as like a tool to be able to look for someone who may suit the needs that you have or that anyone else has, that's a really excellent local resource. And their website is ncamhp.org.
Right. And I mean, the reason I'm saying this is because I'm really trying to figure out, you guys are here as a town hall, and the answer is God is I don't know.
Well, we've had multiple psychiatrists and doctors of all kinds leave their practices, and we have not had more come in to backfill for that. So I acknowledge that there's a unmet need in our community, and what can we do to recruit?
Well,
like
I mean,
that?
I'm hoping I'm bringing light to the situation and saying, since this is a town hall,
Yes.
that you guys need to like maybe shine a light on that.
Thank you. And it's something.
But I
that
appreciate it, and I just want to say while I'm up here, thank you. You guys are doing some good work, and I really appreciate you guys. Thank you.
Thank you for shedding light on that issue and coming up. Next question.
So my name's Rick Bowman, and this would work for this guy, the VA. So I want to share Smart Recovery with our community. Smart Recovery is an alternative to AA, or they also have
Rick,
friends and family.
sorry to interrupt. Do you want to just take a step to your left in front of the microphone? So there we go. Thank you.
I'm wanting to share Smart Recovery with the community. Smart Recovery is an alternative, the 12-step. It's REBT. It's cognitive behavioral therapy. And I'd like to leave these pamphlets to help anyone who wants. And that's all I have to say. Except for I would like to say, when you're talking about ordering people into programs, there is a law that you have to, you can't just order them into religious programs. There's an alternative here, Smart Recovery, so if they need a choice.
Is that just for veterans, or is that a community open to anybody?
It's open to anyone. You can read the pamphlet. If you go online to smartrecovery.org, really cool website.
Thanks.
Really cool. And you can find me on there. Just type in your zip code.
Thank you.
I had a quick question for him for that program.
Hang on, Rick. Hang on.
Do they do sign-in sheets? Like if they did?
Yes,
okay.
it's totally open.
So they would be able to provide proof?
Yes, proof from the court. It's all been okayed from the court, actually since 1996.
Okay, great. I'll take one of those.
Laura, do you mind just grabbing a couple of those for us so that we can help spread that resource? Thank you. Thank you, Rick, for sharing that resource. That's really excellent. Next question. Oh, wonderful. Thank you. We will save that for when we get to the note card questions. Yeah, thank you.
And I was going to actually ask.
By all means.
I was going to ask if you are going to be addressing the emailed ones and also the.
Yes. Yeah. So any questions that were emailed ahead of time, we have those written down on note cards, and then after we kind of cycle, I'm noticing we have a long line of audience members standing, and so I want to make sure that we can get to some of those, and then the ones that we have written down, we'll cycle into that.
Okay, great. So my name is Dr. Katie Wilson, and I am a psychiatrist in California. I'm also a psychiatric patient. I suffer from depression, and I take medications, and they have saved my life. So I just want people to know that most of us are both providers and patients. So I prepared a bunch of stuff, which I won't have time to do in this venue. However, I will be forwarding 3 questions and 4 suggestions to the Board of Supervisors and County Mental Health in my effort to continue to give psychiatric input about the community. And so partly because I've worked in public sector psychiatry my entire career. So for 25 years, I've treated the most severely ill patients, including the ones that Leah used a word that's very important, which is anosognosia. And so I won't give a lecture about that, but that actually is extremely important as far as addressing the treatment of the folks that we see that have severe illness and don't recognize that
And real quick, just for the audience, anosognosia is the symptomatic lack of insight. So the illness actually causes the individual to not be able to recognize that they're ill.
Yes, and it's a neurological brain symptom, and sometimes medications don't always address it completely. And some folks with severe mental illness and substance abuse difficulties also have anosognosia. So I had several suggestions. The first is that the interpretation of the 5150 statute is actually subjective in the sense that different clinicians interpret either more narrowly or more broadly the criteria for whether somebody meets criteria for danger to self, danger to others, or grave disability. So I've been recommending to our county and our Board of Supervisors that I recommend that that be looked at more carefully to determine whether there are times when some of the clinicians are defining it more narrowly, and therefore people are either getting released off holds quickly or they're not even get put on holds. I am going to use a name from the community because this is a person who was in the newspaper, so it's not anyone that I treated personally. I don't know him. I don't know his family. But one example is Jacob Steichen. And so for anyone who doesn't know, he was not put on a 5150 hold. And from reading the newspaper article in the Times Standard, there was a series of articles about what happened with him, and they included some specific records from the psychiatric chart, the DHHS chart of Jacob Steichen. And so it's clear for anyone who wants to read those articles that he did meet criteria to be put on a hold, and he was not put on a hold. And then I think everyone knows he stabbed his brother to death. So the next suggestion is that I understand that DHHS is...
Real quick, Dr. Wilson, do we maybe want to answer that one first? Because I'm wondering, Commander LaFrance, do you want to talk about...
It's a suggestion more than a question, but...
Totally, but I think there's actually been some work that we've been working on in standardizing the approach to 5150s. I don't know if you want to talk about that.
Yeah, so for law, I can only speak for law enforcement, but we developed a training last over the, granted we've been doing the mental health work for the past really 5 years with CSET, but last year we developed a training program for all of Humboldt County for all law enforcement. So we're trying to get all law enforcement on the same page. And so what do you look for when someone's danger to self, danger to others, gravely disabled? And so we actually have a set standard across the board for law enforcement. Because I agree, I think some people take it very narrow. Sometimes, we'll look at a client and say, well, historically A, B, C, D, and E, all the way to Z. Based on totality, we have to do it on hold. If we don't, it's going to be immoral or unethical. And so we move forward with a hold. Also working with the hospital to make sure they have a bed open as well.
And I thank you and I commend you because you're one of the people I think that's having a lot of positive direct impact on our community. And I mostly am speaking to the clinicians from DHHS that are either putting people on the hold or taking them off because they're the ones that decide whether the hold should be rescinded or not.
Sure. Yeah,
so that's just a suggestion.
Yeah, for sure on R&D, for law enforcement, again, we're trying to get everyone on the same page, at least for law enforcement, because that's where most of the holds come from.
I think that's awesome.
Leah?
So there is a bill in Sacramento.
Know about it.
And I don't know if it's passed, but
it's not passed yet.
What it says basically is someone can be gravely disabled if the family's providing food, housing, and the basic needs. If the family takes that away, the person could die or would be gravely disabled. And we as family members are often helping so much that we have to actually stand back, this is in the case of Jacob too, and maybe not provide food or housing or stuff for our family members, which as a mother, as a grandmother, that's not going to happen. So I'm glad they're looking at the term gravely disabled and considering how much families and caregivers help to keep someone from dying, basically. So I just wanted to add that.
Absolutely. And that's State Bill 232 and also State Bill 43. And they're not laws yet, but they both were just introduced in the last 2 months. So it's very exciting to me because I agree that that's going to be ultimately one of our solutions. So the next suggestion, I'll just do one more, is that so DHHS is chronically understaffed with service providers and have said publicly, and I know that this is everybody's fault, nobody's fault per se, but that there's that it's really difficult to recruit people to come and work. And so there was an announcement made by Paul Bignacki from DHHS that there was one case manager for 700 people, okay, in the adult outpatient clinic alone. So my questioning in my mind is always, how can that be? Why are some of the people that are working in that building that are not directly helping patients spending some time helping patients? So my suggestion is that all of the DHHS administrators and program supervisors each spend 4 hours a week doing direct case management. It would not have to be, thank you. I've given this so much thought. Probably, I don't know if many of you don't know me, but I worked for county in the jail and in the adult outpatient clinic and the older adult patient clinic. And so I've had a lot of the blessing of being able to work with a lot of you and really just trying to find creative ways of improving the services that we have. So if, for example, there's 10, I don't know how many there are. Dr. Lammers can probably give us some data on this, but let's just say, for an example, there's 10 administrators and program supervisors. If each one of those people took 4 hours a week to do direct patient service, and I'm not talking about clinical service because obviously non-clinicians can't provide clinical treatment. However, what a lot of our folks need is case management. For example, rides to the shelter on the other side of town so that a person can actually get in to a warm shelter bed. Another thing from the news. So I'm really nervous right now, which is why I'm like kind of stuttering. I have my own trouble with public speaking and anxiety. However, right. I also literally cry every time I see someone die in this community of things that were preventable. So the person that died in the dumpster, being crushed in the dumpster, I read carefully what was written about her in the news, and I have all the copies of all the news articles. I'm not speaking about HIPAA health protection information because I didn't know her. However, there were some things written that made it seem that she and a number of these other folks that have died recently may have had anosognosia. In other words, not being aware that they were ill. 50% of patients that have severe mental illness, which includes bipolar disorder, schizophrenia, schizoaffective disorder, and related disorders, have anosognosia, which means 50% of our folks, I call them my peeps, like the people that I saw in the jail, they never would see a psychiatrist outside of treatment, outside of the jail, because they didn't get the case management that they needed to go get their medications, go get their clean and sober house, reconnect with Medi-Cal, reconnect with a primary care provider. A lot of these folks, they also have what's called anergia, which is not having the energy or the drive to do things like filling out forms. And that actually can be one of the symptoms of schizophrenia, which is called one of the negative symptoms where people don't have the drive. So I think sometimes we're expecting people to do more than they're capable of doing. And what I would love to see is that more of all of us, and I'm actually willing to do it too, to be able to provide direct service. And so there's I was saying if there were 10 administrators and program supervisors that each devoted 1/2 day a week, so 4 hours a week, then that would be 40. I think I tried to figure it out before. My math is horrible, but that would end up really making a difference, because each one of those people would do a certain amount of tasks, and that would actually help those 700 people that only have one case manager. I just have one more thing to say, and that is that the Welfare and Institution Codes for 5170 and 5230 do provide for patients whose emergency is due to substance use disorders to be treated involuntarily if they're in an emergency. And so it is true that the 5150 excludes, if you turn it over, Dr. Lammers has educated me about this in the past, when you turn over the 5150 form, it will say it excludes that if the person's emergency is due to substance intoxication. However, if a person is under a psychiatric emergency due to their substance use difficulty, they actually, if they're a danger to self, danger to others, or gravely disabled, they can be treated under these two welfare and institution codes. It is complicated because the county has to be willing to provide the treatment, but the treatment does exist. I'll stop now. Thank you very much.
Thank you for sharing. Go ahead. Yeah.
Dr. Wilson, thank you for your advocacy. It's much appreciated. For what it's worth, I mean, we talk about the shortage of psychiatrists and clinicians. In my opinion, we get more bang per buck with case managers than with anything else. And if we spent the same amount on case management that we spend on higher levels of service, we would have much less need for higher levels of service. I mean, that's just the math. Totally. And I advocate for that all the time. I provide some supervision for our comprehensive community treatment team, folks who have essentially bachelor's level backgrounds who are, beautiful public servants. They do this often because they have lived experience or family members or own their life experiences that have drawn them in this direction, and they provide tremendous care in direct, immediate contact with people that sometimes have no other associations. These people are can be very socially isolated and compromised, and our case managers do a really heroic job, and I'm grateful for them, and I appreciate them, and I tell them that all the time. So thank you for that advocacy. It's much appreciated. Welfare and Institution Codes 5170 does provide for involuntary treatment of chronic inebriates, but it basically has to be put in place at the county level by proclamation by the Board of Supervisors in some regard. And that goes back to the days of like the county farm, where they put people in a place to dry out when substance use essentially was alcoholism. That was all there was. But now there's no county in California that has put in place the means to involuntarily treat people for substance abuse issues. So we're pioneers. So just saying that, that when they drafted the Welfare and Institutions Code, they recognized that was a problem and put that in the code in order for counties to take advantage of it if they wanted to. And imagine what that would look like. I mean, you could be a person who got a DUI and all of a sudden you're involuntarily treated for your substance use issue and we're putting you away for a month or 90 days or something. I don't know. But look at the substance use issues we now that have super more complicated than just alcoholism and what that would look like. It's hard to imagine, but it would certainly benefit people and keep a lot of people more safe who really do not meet with great success when they come into the mental health system. And there's a...
Can I just ask, when you say that the counties have to recognize the problem, is it on an individual basis?
County by county, yes.
No, but each individual, there's a whole...
No, what the county...
Just the whole thing, the county recognizes it, and then if somebody does get a DUI...
Well, what it would mean would be like the county would have to put in place a system of care comparable to what we have with DHHS, with this integrated system, right, that provides treatment for mental health issues and a bunch of other things, public health. that would be dedicated to substance abuse treatment. What all counties in California have done is to basically support and promote the use of nonprofits or the medical system or things like AA for substance abuse treatment, versus saying we recognize this as a community problem, we're going to allocate funds to it. Hard to even imagine what that would look like or what the expense would entail. And if there was a will for that at some level, it might happen. When that responsibility falls on the mental health system, we're often not able to provide real success with it.
Thank you for the follow-up question. I do just want to encourage that folks hop in line if they do have follow-up though. But thank you. That was a good clarifying question. Leah?
I just wanted to mention again, Waterfront, Dr. Ruby Bayan has, her psychiatry is in addiction and mental illness. So they do have a detox program, 30, 60, 90 days. It is voluntary, not involuntary, but it is the only program like that in Northern California, and they can now Medi-Cal bill. So I just wanted to remind people that that does exist here in our county.
Thank you, Leah. That's a super important reminder. Thank you.
Hello, my name's Joanne McGarry. I live in Arcata, but I come to Eureka because Eureka seems to be doing a lot more in trying to discuss these issues that concern the community. I just want to preface this by saying I'm a little hard of hearing, so when people can speak loudly right into the mic, whether you're on the dais or here in front of me, it's really helpful. Because hearing disability is one of those things that many of us have in the community. And that goes to what I'm going to talk about today is that I have a background in animal welfare. I worked for 16 and a half years at the San Francisco SPCA, mostly in administration, but did a lot of work in the shelters and in the kennels and helped foster. And we had a hearing dog program where we actually trained former shelter dogs to be hearing dogs for the deaf and hard of hearing in our community. But one of the things that has come up for me in the world of the 21st century is this new use of animals for our mental health. And I think animals, companion animals of whatever type, can provide a lot of support to people, but I get really, really concerned, and it's not just for people unhoused, but for people in huge mansions, and I've seen it in San Francisco when I lived there, that we do not do well oftentimes when we are mentally ill in the welfare of the animals. And I'm really, really concerned about many of the animals I see out in the community being designated as emotional support animals, therapy animals. That's very, very different from a trained service animal like a guide dog for the blind and all. And there are people in our community who end up not getting services because they depend on their animal, and there's oftentimes circumstances where their animal cannot be accommodated where the person needs to get the services. So I'm not trying to take animals away from people. I want that to be very, very clear. But I also want everybody up here to really appreciate that I see a lot of concern in the community from housed and unhoused people that are not doing right by their animals. And I know dependents of people who are mentally ill have child welfare services, and I think animals deserve that kind of attention too. And I really want to strongly urge the emotional support concept as really being concerned about the welfare of the animal when you look at signing a piece of paper that says, well, I can say that this person needs an emotional support animal. We want to make sure that that animal is treated well. And I just want to say that in a mental health way, because we can overdo our substances with medication, and the same thing is we can also abuse the use of an animal for emotional support. Thank you.
Thank you. Leah?
So you hit on a really important goal of mine, I think, and I think it's a goal of Humboldt County Mental Health as well. It would be wonderful to have just a small group of people that would be willing to adopt a little or take care of an animal when someone is hospitalized in Sempervirens or CSU. NAMI Humboldt is interested in that. Most of us are overworked. We're all volunteers anyway. But I think that's a fairly, I mean, it could be kind of a simple need for somebody to watch a dog for maybe 3 or 4 days, whatever. Anyway, I applaud you for being concerned about these animals. I know for my own son who's mentally ill, his dog is wonderful. It's some reason for him to get up. I am helping him when he is hospitalized. And what happened was neighbors came to me and said, "Oh, we love this dog. We'll help you," because he lives in McKinleyville and I live in Arcata. And it's wonderful to see people rise to the occasion to help out with that issue. So I appreciate you bringing that up.
And just to clarify, that's a companion animal like I would have or anyone else would have, whether we have diagnosed mental illness or not. A companion animal, emotional support animal, I'm really wary of. So I just want to say that. Thank you.
Mm-hmm.
Next question.
Hi, my name is Holly. I'm a parent who has a child with bipolar, and I am wondering what we're going to do for when they're in crisis. Recently, my son's had a couple holds, and we end up at the hospital. So I'm wondering what we could do to avoid the hospital stays.
I'm sorry, the hospital what?
The hospital stays? Like, what do you do for crisis?
So, like hospital, like in the emergency room at
Correct.
the hospital? Yes.
So right outside is a little NAMI booklet that says how to handle a crisis. It's full of information for you. The other thing I recommend, of course, is hanging out at our support groups and getting ideas from other parents who have life experiences. And it's a challenge. I've been there, done that with grandkids and my own son. So I know how difficult it can be. But gather all the information you can, talk to me later, and I'd love to give you all the support that NAMI Humboldt can give you.
Well, I'm just wondering what we're going to do, though, for future. Like,
can I mention that hopefully coming online here, I think in the fall of 2023, is Sage Leaf House, which is out in Indianola. It's going to be a crisis residential residence for youth in crisis. So hopefully we will be able to manage more appropriately youth in crisis here in the community, which I think anybody would recognize is the preferable thing to do.
Mm-hmm.
The county currently has no inpatient psychiatric beds for anybody under the age of 18. And as a consequence, they're transported out of the county to what's considered the appropriate level of care. But of course, the stress that puts families under, being a distance away from the child who they love when they're trying to support them in a crisis. Similarly, the long stays in the emergency department, which happen for minors and sometimes for adults as well, which is a consequence of our psychiatric hospital here has 16 beds. And often we have any number more people than that waiting in emergency rooms for treatment. There's a statewide shortage of beds currently. So these prolonged stays are something that's really, really recognized as a systematic problem, not only here, but across the county. One of the things that the county has done is put together a mobile response team, specialized for children and for adults, where they go to the hospital to try and do what they can to provide whatever intervention at that level is going to help get that person out of the hospital as quickly as possible. We recognize it's a problem. We're really trying to work on it and really appreciate the support of family members with that process while it's going on. Really looking forward to having more step-down crisis residential services for youth and adolescents and minors here in our county in the short term here, because it's really a huge need. We want to keep our kids here where we can help them. We have good services with CYFS when kids are stable and doing well in the community, but when they're in crisis, it's been really hard for everybody.
so what do you do when they're like 21?
I was going to ask. Yeah, I was going to ask you how old. So over 18 is a whole nother ball game. So, Yeah, there is a mobile crisis team that is wonderful. They do support families, and the crisis line, which we haven't really talked about here, but it's a 24-hour crisis line, 445-7715, and they could maybe initiate the mobile crisis team to come out. They've also initiated a 5150 welfare check for me. That's another option, and but it is hard. And of course, when they're over 18, you have this whole release of information. They can't even tell you if your kid's up on the unit, and that's a whole. It's such a complicated thing for families. It's so hard to figure it all out. Anyway, yeah, I'd be glad to really help you as much as I can.
And I've put information out on one of these tables as well, roadmaps to care for both. I apologize, I didn't understand the age that you were talking about there.
It's okay.
But they're kids at any age at that point.
I guess my concern is more of, like, there's not, I hear you that you have people that go there to the hospital, but really it's more of a therapeutic neglect that they get there because there is no services. The emergency people are not trained. So...
Well, they're dealing with all those medical emergencies that, yeah.
So what are you doing for them? I mean, I'm not going to take my kid there.
Yeah.
And then there's not much.
I'll jump in whenever you're ready. So yeah, the issues of the hospital has been, I don't know how much time in the past 3 years I've spent on this issue. Probably 25% of my time spent on dealing with 5150s at the ER or mental health holds. Last week, if you're not familiar with St. Joe's, they have 20 beds. They can put 6 beds in the hallways. Last week we had 12 mental health holds out of 26 beds. We've seen it where you had 14, 18, more than half. There's ERs are stacked up with 50 people plus in the waiting rooms. Major medical emergencies happen in the ER in the waiting rooms. As you're familiar with, it's a complete. It's really something we have to address at some point. When we look at the issue overall, at least from the city standpoint, if you live in the city, that's why when we develop programs like CSET with CARE, we want to, if we respond to a welfare check on somebody, we want to have the officers respond, if not CSET, patrol, but they also have CARE on board. We can look at every option. Does this person have to go on a mental health hold right now, or can we divert them to a different resource? And we have the time, expertise, and we have the personnel to actually sit with them, work through it, get a plan together, or we say, you know what, we've done everything we can. Based on this criteria, we have to go on a hold. We've been pretty good about reducing holds by about 50% over a 3-year period. But again, when the person's in crisis, I can give you numbers. It means nothing because these are just numbers. That's an individual experience you have. But again, our approach is we want to go when it's happening. Actually, we want to go in the field, divert if we can, give you options, but then also do follow-up. So if we know the individual, most of the folks we know our clients, we know them well. They have our phone numbers. I get text messages occasionally. I get phone calls from folks we work with. But if we can have that connection with them, often that connection leads us to getting better outcomes and saying, hey, I'm in crisis now. Boom, we'll go to the ER. And now you sit there for 2 weeks and it's not therapeutic. The staff are they're flustered with medical emergencies. People get violent in there. It's been a very challenging past 3 years with the ERs. But again, for us, we really want to try to go pre-hospital and get folks. And that's why we're trying to build up Jaco's program, besides himself and 2 case managers, but adding 2 additional clinicians. And we'd have 3 clinicians total and 4 case managers working 7 days a week that are able to respond to those calls versus someone going on a hold.
And I think the approach is twofold, like going upstream, as Commander LaFrance is saying, and then there's a huge collaborative amongst the county right now to attempt to get grant funding to bring a triage center to our area. That's still very, very early on and unfortunately far away. But the county certainly recognizes that to a degree it's not sustainable and that we can do better than where we're at right now. I understand some of the necessity that we have in the moment to do things the way we're doing it, but I think we're all coming to the table and really recognizing that we can improve even upon that. And there is an effort countywide to do that, and there's an effort statewide to do that too, because the state recognizes that clogging up ERs across the nation actually isn't always the most effective way to treat folks with mental health issues. And so the state is trying to make more money available to build triage centers that can accommodate that, help relieve the ER so that they can specialize in what they specialize in, and provide a more therapeutic environment to do the triaging and diagnosing and kind of crisis stuff. So, but I really appreciate you coming up and sharing your experience and concern, and it's a valid one, and it's definitely heard loud and clear across the state. Yeah.
Thanks.
And Holly, if you haven't connected with I think Officer Clark's in the hallway, that's a good. If you haven't met her yet, she's a good connection and can kind of get you some other ideas going on. So,
okay.
So we can do meet and greets. We can do whatever you want to do. We're happy to help you out. So,
thank you.
Thanks.
Thank you. Next question.
Oops. Hi there. My name's Fern Fernandez, and no relation. I wasn't planning on even coming today, so sorry if I'm stumbling. But I'd like to just bring up another side of mental health. It's like, how's your mental health today? I'm a regular person. I take my meds in the morning. I own a home. I'm retired. I'm disabled. But if my house of cards even fell a little, I'd be like, I need help. So my new job, I've been learning all about the Rapid Rehousing Fund, government fund, technically called the ESG-CV. I've learned that at any time in Eureka, there's 500 people unhoused. They're not all severely mentally ill. My job as the case manager for the Salvation Army is to find homes for these folks. We've got a bucket of money and we want to give it to you, you landlords, you mom and pops, the people with the studio, anything that you can supply a lease, we will pay you. We are holding these people's hands for the next year, fully funding all security deposits, giving you sign-on bonuses, paying their utilities, giving them rides, supplying them furniture. We're here to help the people that are houseless, and they're not all crazy.
And you're at Salvation Army?
Yes, and I'm not the only one. Arcata it's a government program. It's not a county. Sometimes the county requirements are a little more severe than the requirements for this ESG bill. We've decided we'd like to hold their hand, get them in a place, get them an address, allow the services to find them. But it's hard to find the landlords. We need people with compassion, there before the grace of God go I. That's life. That's what people say. Riding high in April, shot down in May. It's like we're trying to get these people housed. They're not all severely mentally ill. And let's help the community while we are allowed to with this government funded grant. Landlords, if we can only offer basically a bunch of money to you in lieu of someone with not the best credit, someone that may have gotten taken to jail because they were sleeping in a porch of a business. They're not going to have the best criminal records, but they're not violent felons. We need the landlords to step up and just give it a shot, because the bill was altered for 2023. We've gotten a lot more opportunity financially to take care of the landlords. And any damages, we have a landlord hotline. So I'm just up here to help at least a portion of those 500 homeless. They're not all crazy. And all the case managers here can help with that part. But let's get these people housed. So I'm just asking people to help out our community.
Super appreciate the pitch.
Thank you. No, that's
Thank you.
Awesome.
The ESG funding, and Jeff, call me out if I'm wrong on this, but Uplift has some of that and is applying for the next round of grant coming up here. And so Uplift Eureka is certainly working on that. And then I know that it's also with other agencies as well. And that's an excellent resource. And thank you for giving a shout out for that. Super important stuff. Next question.
And I would say to all those landlords, how's that Airbnb thing really working out for you? I mean, there's competition for rooms. And it's one of the consequences that leaves people who otherwise would be in entry-level housing, they're perfectly appropriate for it, would be in that housing, except that housing is very, very scarce. Can I just say bless you?
Hang on, Stephen. Hang on, because I'm two things. I'm conscious of the time. I'm also conscious we have a few other folks, so I do want to make sure that they get their chance.
Get out about this because I'm a landlord, and I just spent 6 weeks trying to find housing for a homeless person. We finally ended up getting it with much assistance, and if I didn't know it, I could have rented out one of my rooms.
Have you two met?
Yeah, you might want to get together.
Thank you.
Yeah, thank you.
That's why we're here, right? Yep. I just wanted to thank you guys so much for organizing this. It's so important.
County, the city.
And I'm super grateful that we have taken the time to do this. I'm just super grateful that you guys have organized this. It's so important. And my name is Jen Bruce. I'm a functional medicine practitioner specializing in trauma, mental health, and addiction recovery, as well as chronic illness. I'm also a transformational recovery coach, and I'm a person in long-term recovery. And I'm also a psychedelic integration specialist. I own a home, I own a business, I have an internationally good reputation for the work that I do. I'm a mother, and I'm the first person on either side of my family that's been generationally afflicted with alcoholism, mental health issues, which after 13 years of research, self-healing, and traveling the world, I realize it's not a disease that's genetic, it's generational trauma. I come from military on both sides of my family. I'm the first one to find recovery. And after 13 years of being diagnosed with bipolar disorder, being diagnosed with depression, being diagnosed with anxiety, and being called crazy, that I'm now diagnosis and symptom free. I take no medication. I have not touched a drug or a drink besides therapeutic psychedelics in 13 years. And one of the reasons was because I had to go find my own way. And the reason I'm sharing this is because I want to pose the question to the entire community is, have we looked at the model that we're using, and are we going to ever be able to solve the problem with the approaches that we're currently using? And it's not to disregard the efficacy and benefit of treating with the things that we have for acute situations, right? And that's what the public sees. But nobody started out acute. They fell through the cracks many times. And for me, and every single person I know that has achieved sustainable long-term recovery and total remission of their mental health systems, we've all done several things in common. We have radically overhauled our diet because nutrition is fundamentally important to brain health. We have learned how to regulate our nervous system because we've identified underneath the mental health challenges that we've had, it was unhealed trauma. And medication does not heal trauma, which is why we see people going through the door revolving. And it's not the drugs in this community that's the problem. It's not the mental health that's the issue. It's the unhealed trauma for the most part. And if we were to look through the DSM-4 or DSM-5, which is a diagnostic manual for psychiatric disorders, which was only written about 95 years ago and is still out of date even with the newest edition, that 80% of those diagnostic labels would become obsolete if we look at it through the lens of trauma. And if you want to know where to recruit people, there are thousands of people going through Dr. Gabor Mate's training right now, if you're not familiar with him, that are desperately looking for employment and are motivated to change how we do mental health care and would gladly relocate to somewhere where they can clearly see that the nature here alone is one of the most powerful tools we can use for healing trauma, and it's free. That we have ample land to grow nourishing foods so that when we end up in hospitals or prisons or jails that we're not further depleted. I've been through the mental health care system here and it was traumatizing, and this is nothing to be personal towards anybody. I've also burnt out in my field when I was using things that didn't work the first 5 years. I've also sponsored many women in 12-step community. 12-step saved my life, but it didn't take care of all of the stuff. I taught 12-step workshop to over hundreds of people over 5 years here, and I volunteered. And what I've seen is that everybody continues to struggle because we're not healing the real issue, which is the trauma, which is physiological. This isn't just a homeless street level problem where the money's the issue. I've had the privilege to work on pilot project for Navy SEAL Team 6 veterans that were serving directly under the United States President. And they were in the Mayo Clinic with all of the resources available on the planet in the Western model, and nothing worked. And then I was privileged enough to work with them in the setting of Ibogaine, which is a specific psychedelic, which is very powerful for trauma, and it's very powerful for addiction. And in 1 week, they were better, completely better, after 10 years in the Mayo Clinic. So I'm not saying that what we have isn't good enough, but like when I go into a mental health clinic, or I've had clients where I've had to work to get them out of the community where we can go get them the help at the clinics, where I'm seeing 96% success rates where they're using some of these tools I'm talking about. And I've come up against so much opposition from the emergency staff, and I'm polite and I'm professional and I'm highly, highly trained. And I work with people all over the world. I've traveled all over the world, and they were treating my clients, and when I was in the system, like we were homeless and that we didn't matter, and that we were drug addicts and that we didn't matter. And it's ironic because the opiate epidemic right now that we're in the middle of is a result of overprescribing and the pharmaceutical companies incentivizing these prescribers. And then you go into the doctors that are prescribing and they treat you like you're not human. And so I'll wrap it up here, but you know, Sempervirine, same thing, and it's not personal. People are burnt out. But the problem, there's no question what the problem is here. It's whose problem? It's the community's problem. Every single one of us in this community, if we have a sick community, it's the whole community. And it starts with trauma informing every single person in the community, especially the people that are working on the front lines, because treating somebody like they're a criminal or that they're less than human or that they're too busy with more important things to give them the care they need, even the lighting. I tried to volunteer. I'm a trauma-informed yoga teacher that I trained with the best in the world. I tried to volunteer at Waterfront, and they couldn't find the time to let me in to volunteer. And I spent multiple six figures on my education and just wanted to give back because yoga is one of the most potent things I've done to heal myself. And there's no sunlight over there. Sunlight, circadian rhythm is one of the most fundamental parts of our mental health. There's nowhere for people at Waterfront to go outside and get sun. You know, the food is malnourishing. And so I'm just saying, like, if we want to fix this problem, we've got to start from the bottom up. We've got to trauma inform everybody, and we've got to bring in some different tools that actually work, because what we're doing right now can help, but it does not a standalone model. And so I have so much more to say, but I'll let it go. And I hope I would quit my entire career if I could be funded enough to dedicate the rest of my work life to helping this community find a solution, because we were brave enough to not listen to the state and become the leading producer of cannabis when it was against the law in this community. So I think that we can take that same gusto and grit and say, screw the rest of the state and screw the rest of the country. We're going to do it our way and come up with a model of excellence that we can show other communities how to take care of their people too.
Thank you. Next question.
Can I just reflect back that some of the things that you're talking about are really super interesting, and there's lots of interest at all kinds of levels of really trying to find a way to put in place some of those therapeutic benefits. So I appreciate what you're doing, and it sounds like you're going through a lot of personal sacrifice to thank you, and also to reflect, you know, on a community level that being trauma informed is critical here across all of our agencies. That Humboldt County's got one of the highest rates of what they call ACEs exposures, adverse childhood exposures, which are recognized to lead to all kinds of serious downstream outcomes from things that happen, which here are multi-generational. And I just wanted to reflect back to you and appreciate you for bringing that kind of stuff up, because it's something that here as a community we need to look at the implications of multi-generational genocide in our community, at the problems of the multi-generational outlaw communities, essentially, that brought us the pot culture here, that these things have repercussions in our community that are traumatic and that require healing in lots of ways. So thank you for your participation in that, and I appreciate hearing what you have to say.
One more, I'm sorry, one that's really important to me because it's important.
Hang on, come up to the mic.
I got to witness when the last client I had, he was in a 23-day psychosis, and friends of his, he was a well-known DJ in the community. He comes from an affluent family from Marin. He was up here at HSU. He was working. He fell into drugs and alcohol in the cannabis scene. and had been in a 2-day psychosis when I called on the job. And his mother had come up, and he was 30, and he was big, and he was violent, and he was not only schizophrenic, but displaying 6 different personalities. And me and another person sat with him for 23 days while we were going through all that stuff with the hospital and Semper and hanging up the phone and all. It was just a nightmare. They hired celebrity level interventionist from LA. He came up for 1 day and left because he's like, this is the worst experience with the mental health care system. They will not work with me. So he left. And then we finally got him. He was schizophrenic. So I was walking out on the street, seeing all the people out on the street just like him. And I was like, oh my God, if I don't figure this out, this mother's son is going to end up just like that if he gets to live. And so I did research because he'd been doing nitrous oxide, and it turns out that nitrous causes a B12 deficiency. And when you have B12 deficiency, you go into psychosis. So we finally got him on a plane to Las Vegas at the clinic where we're seeing 96% success rates. I'm a good friend with that doctor. He's discovered something. I'm telling you. He was out of his psychosis in 3 days. Everybody was saying he was going to have to be checked in, but they wouldn't keep him. They'd medicate him, put him out, and then he'd have to be on heavy meds the rest of his life. He's 30 years old, brilliant. 6 treatments that we went through with the other work that we do, and the trauma therapy, which enabled us to keep him calm through the process. He has no psychosis. He's completely medication free. He went to treatment. He's 2 years sober and back in law school right now. So that's what's possible. Okay, so I just wanted to say that because the people that you end up on the street that we say didn't get the opportunity that that young man had with me. Okay.
Thank you.
Hello. I heard you say something about, the 72-hour hold. How does that exactly work for, the police been to my house? All the police department knows who I am and my girlfriend. So supervisors, I call, ask them for help. They hang up on me, right? So then the police come. I asked them to, put her on a 72-hour hold. So, and they wouldn't take her until after she's way sick. So how is that helping her? You're letting her get worse and worse and worse, and nobody's granting a 72-hour hold. So you wait until she gets so sick that you rip her from her home and then throw her in a mental hospital. I don't understand or get that. So what exactly is the 72-hour hold, and how do they get in there? Because when you call and ask for help, you get denied. So tell me why that is.
When somebody calls the crisis line, or SV, and says they have a family member or a community member in crisis, what SV is able to do is to ask law enforcement for a welfare check, which, because we don't really go out and put people on 5150 holds in the community. If somebody comes to same-day services or is in our facility, we can put them on a 5150.
But a year and a half, sir, of her getting worse and declining in her mental health. A year and a half, and you couldn't. No one could bring her in for a 72-hour hold. I don't need candy for my ears. I need the truth, because that is unacceptable. And like when I went into Semper Virens to get my girlfriend out, your doctors told me, "Oh, here's a phone number you call, and we'll come and help." That's bullshit.
Are you in the city?
Why
or in
is
the county?
that?
Are you in the city or county?
City.
You're in the city of Eureka?
Yep.
Okay. So yeah, I'm not familiar with you. I don't think I am.
Are you in the field? Do you come out in the field?
For the past 15, 16 years, yeah.
Okay.
However, one thing, so say if the officers do respond, there's a welfare check called. Officers who go out there, there's criteria we have to meet to lawfully detain this person and take away their freedom. Otherwise, it'd be a violation of the person's rights. So if they are placed on a hold, obviously they go to the ER. If they don't meet criteria for the hold, what they can do is if they voluntarily want to go, we can transport. They can go to same-day services, CSU, over at 720 Wood Street, and they can talk to someone voluntarily. But again, the caveat is if they don't meet criteria for a hold, we cannot force them to go, and that's where the law is for us.
And what that means is that they are specifically saying that they are a danger to themselves, they're suicidal, or that they're a danger to others, homicidal, or they have no place to go and no way to secure their safety. If they have a place to stay, and
she had a roof over her head, she needed help with her meds because, like I said earlier, mental health, when they think they're better, they get off the meds because it's their right. And hey, that's all good. But then when they get admitted, you gotta fight teeth and nails to get them out.
So
And
this is
now
one of the-
conservatorship, yeah, like it's a non-winning fight. I'm not giving up on her, but I mean, this is 100% unfair.
And this is one of the difficult things with our system right now and the set of laws that we have is that there's often a balance between the person's individual rights as well as their need to be treated. And it really puts a limit on the system because the pendulum has swung in that direction. If you look 60 years ago, the pendulum was in the other direction where someone could swing by and drop their wife off, say that she had lost her mind and she'd be admitted for the weekend. And it was really determined that that wasn't appropriate, obviously, and that we need to move away from that, right? And so it's a constant adjustment. That pendulum's constantly swinging where sometimes we're favoring over-treatment, sometimes we're favoring human rights, and it's a constant adjustment to get back to that middle balance. And it's really difficult because then there's families that get trapped in the middle of that where someone may not be sick enough to get inpatient treatment, but then there isn't the service in the community that they need acutely.
Like I was saying, a year and a half I've been asking for help. And then now you just go through the dramatic rip her away, lock her up in the mental institution. And yeah, like literally I was asking for help for a year and a half. And then he's went to the extreme of ripping her out and not like I just hear excuses.
Hey, Charles, can you just leave your name, her name, and then a contact for you guys, and give it to Laura right here, and I'll follow.
She's in Crestwood.
Okay. Just leave it for us so I can actually look at it. Also, we work with Crestwood quite a bit. Also, okay.
That's not going to change anything because she already went to court and conservatorship. Basically screwed us both. They don't. Not one doctor has called me to come in with a one-on-one consultation to see what's really going on. So, your system's totally. How much does conservatorship make off each individual?
I'm not entirely sure that, conservatorship's incredibly expensive actually in placing people because the state actually, when their rights are taken away, the state takes control of that person's rights.
But there's a price for each head.
Not
a money-making operation.
Yeah, it costs the county a lot of money.
Okay. But then release my girlfriend.
Well, that would have to go through the legal process. And Charles, I super appreciate you bringing your experience. I know that I hear that it's frustrating. It really does sound that way. I do want to be conscious of time and that you had checked in earlier.
I get it. I get it.
A couple other folks that I'd like to be able to get through.
Thank you.
But if you'd like to talk with us afterwards, please hang out and someone can check in.
That's cool.
And leave your info with Laura too if you would like to. Thank you. Next question.
My name's Harry Wilcox. I want to thank Kim, the mayor, for this entire situation. It's nice to see things coming out in the open. I'd like to thank the panel for being here and for your time. And I'm from New York City originally, and I went to the capital of New York, Albany. I came here 18 years ago, and I saw the issue with mental health and street people. And I've met with several times with the mayor and with Kim and other council members. And I came before them with an idea that I saw work in the streets of Albany, New York, when we had people. Albany gets down pretty cold at night. We're talking in the sub-zero temperatures. And I know this is crude, but it got to the point where even firefighters, which is what I was, I did a firefighter paramedic, they call them bumsicles. These were people who would die in the street and freeze to the ground. And we had to do something about it. So we got in touch with the whole group, consortium, everybody, police, fire, everybody. And we created something called Homeless Action Committee. And we bought 3 vans. We staffed them with a volunteer driver, State University of Albany is there, and they have a psychological whole thing, and they volunteered their students to ride. And we had a police officer who volunteered to ride so that the rights of the people we would encounter would not be infringed upon. Well, they also had made arrangements with the psychiatric center for what they call the receiving center. They both had the alcohol receiving center and the psychiatric receiving center. These were just places where they brought the people that we picked up out of the streets to get them out of the cold. Basically, that's what we were doing. You know, we'd hold them for, if you were an alcohol drunk, we'd hold you for 4 hours and then release you. If you had psychological issues, they'd take you over to the hospital, evaluate you, and then bring you back. I don't see, and also I was glad that he brought up the triage center. John Shelter's been talking about the triage center for 6 years that I know of, and I've worked with John a lot. And the idea is just a place to bring people who are homeless in the street to access services and to give, provide services and give them a place to be. We've had, now that I know of, at least six deaths of homeless persons or houseless persons, if that's what you want to call them, that are needless. They should not be dying in the streets. If we had 3 vans staffed and running 24 hours a day, you can't ask the police department to constantly be checking bus stops and places like that. But if you had a van a group that's what they were dedicated to, I think that issue would start to go away more. Because the issue is there's nobody on the streets at night. I know I've walked them. And there's nobody on the streets at night. Right next door here, you have somebody who sets up camp about 5 o'clock every night. You know, contact needs to be made with these people. There are also, like you said, sir, that situations where you may have to 5150 these people because they're so altered. You know, to me, I was homeless. My ex-wife threw me out in the street. I was in the street for 18 months. Okay? And yes, I've done heroin. I've been an addict. So I know how it feels to be in the street and what it's like, because what happens is you get homeless. You don't know where you're going to do. You don't know anything. You don't know where all the services are. But if there's a van that pulls up to you and says, here's what we can offer you, you're liable to get off the street and start your road to recovery. It took me 40 years to totally recover, but I'm standing here before you, 18 years clean, sober, and standing on my own 2 feet. And like I said, I have come and spoken. I have spoken with every council member in private. Me and Kim had private. I brought this issue up to you. And that's why I'm saying thank you for giving us a forum to bring this out. And maybe this time my idea will be heard. Because like I said, John Shelter's ready tomorrow to jump in and open the triage center. You guys are doing a great job, what you can. The police department, my God, you guys are overworked, overtaxed. You know, it's really hard for police officers who have 60 calls waiting to go respond to somebody who's disruptive. If we had, like I said, those 3 vans, you could probably get them donated from the right people, you know?
What I can say is we already have the vans, and that's actually what my team's going to be, is we're going to be out there engaging in that kind of outreach.
The idea is, I know you have outreach, but if you have it 24 hours a day, and they're cruising, and they see these people, pick them up.
Absolutely. We aren't going to be 24 hours a day to start. We are aiming for 7 days a week, and we are staggering our shift times based on 911 call data that shows when the bulk of mental health issues or disturbances arise,
which is usually nights,
so that we can actually go into the evening. Our goal will be to have case managers who are out engaging folks proactively, but then also who can be pulled to respond to a crisis when needed, and that's collaborating with the CSET team.
Are night times. That's when we're finding people in bus stops dead at 7 o'clock in the morning. They died hours before. If somebody had made contact, that wouldn't happen. We've had people hang themselves because they didn't know what to do, where to go, if somebody had made contact. I'm just trying. I hear people coming up and talk about psychiatry. You guys are doing the best you can with what you got. And I see that there's that gap in between. The people are out there and the services. We need to get those together. And if that intermediate step is a van, people out there, then why don't we do it? I'm sure the money can be found.
We're definitely working on it, sir. I appreciate
Thank
that.
you.
Commander,
Thank
do you
you.
have anything that you want to add to that? Or
Yeah, so Navigation Center, that should be coming in. I don't have the exact dates on it, but that should be coming in, I'm guessing, the next 18 months. I believe, don't quote me on that. So
One more thing, CSET is doing a hell of a job. They've cleaned up a lot of stuff down in Cooper's Gulch, but you need to get in there a little more often because we've had knife fights, people beaten up, homeowners are harassed constantly. My house, it's directly behind the green space that is Cooper's Gulch. So you guys are doing better, but
we're trying.
Keep working.
All right, thank you.
Thank you.
But also on Tuesday we had the meeting about the authorized encampments. I can't make the exact title of that meeting, but John Shelter did speak during that. I know John. I work with John. Encourage him to pass over his business plan over. That'd be great to see, and that would be at least good to see that. And we have the framework. I think this really start the discussion moving forward, and then also for the outreach. Yeah, we have Jacob Steam building up. We also have Uplift Eureka with Robert and Larry. Again, we have grandiose plans, but sometimes getting from point A to point Z isn't as easy as just making it happen tomorrow. But it's definitely on our forethought. So thank you.
We're moving there.
Starting at point A, what about volunteers that have a little background in?
Absolutely. I actually took a mental note of that and was going to go back and look at how that framework might be able to work. Absolutely.
Do a commercial. Hey,
Yep.
come on, follow me.
So I do want to be conscious of time. I want to respect our panel. They've graciously donated a couple hours today. So I want to do one more question and then we'll move into just some closing remarks. For folks who wrote in, my apologies. We are definitely at time. We're going to hang on to the note cards, and if there's ones that are appropriate to another town hall in the future, then we will do our best to get those questions out then. But Tim, if you want to come on up.
Yeah, my name is Tim Ash. I just wanted to, I'll make a couple statements and then I wanted to ask a question. Basically, I just wanted to kind of remind people, preaching to the choir, but these are no-fault brain illnesses we're talking about here. And I don't think our community gets that as a whole. Probably everyone in this room gets that. But I just wanted to say that. And then the other thing is it's kind of all about the Benjamins. Since I got involved in this issue close to 20 years ago, there have been a lot of improvements. Most of them have been mentioned. Some of them are on their way: crisis residential, triage, CSET, care, the diversion, court diversion, MIST, AOT. All those things are positive. I want to recognize that they're positive. But we have a long way to go. And a lot of it, I mean, we heard a little bit about housing. But if we had vacancies of housing, I guarantee you the cost of services would drop significantly in the community. We just don't have it. Law enforcement picks somebody up, and this has been going on for 20 years. Where do we take them? And we're gradually solving that problem, but it's a long way from being done. And one person talked earlier about, it sounded like what they were thinking was jail was the solution. But again, put a person in jail for 2 years or prison, 2 years, in 2 years they're going to be out. So, and when they go in there, they're victimized. They can be violent. They get put into solitary. You want to talk about trauma, put a person with a mental illness in a jail. It's not a place for a vulnerable person. I'll skip a thing on the history of the mental health court, but we did try to do that in 2008. I chaired a committee looking into it. Everybody in the community was a public defender, the DA, law enforcement, mental health, and a judge. Everybody there was, let's give it a try. But mental health didn't feel like they had the resources to support it. And both the judge and the DA expected that. They said we have to have people, case management in the community to make these people be successful if we don't incarcerate them. So that kind of fell through. But the question that I have is, we talked a little bit about changing the law on grave disability, and there's no question in my mind that needs to happen. There is the issue with inconsistency, and I just quickly, I know of 2 people down in Vacaville who had a brother on the street for 15 years. This man had a traumatic brain injury from a motorcycle accident. He also had schizophrenia. From the motorcycle accident, he was also blind. He was difficult to place in facilities, not because of him necessarily, because of the facilities couldn't deal with him. Every year, his sisters were wondering, 15 years on the streets, he had a support. He had people bringing him water and clothing, and people on the street would beat him up, steal his stuff. Every year, his sisters would say, I wonder if this is the year he's not going to make it. And this is the year he didn't make it. And they could not get him to be found to be gravely disabled. He walking through the streets, blind, hit by cars twice. So, Jacob, you talked about the balance. It's not good.
Hear you.
So the question is on the grave disability. There's laws that are looking at expanding the civil commitment statutes so that people could be caught further upstream, and caught's not a good term, but they could be intercepted upstream a little further than being imminently dangerous to themselves or others. And so what you guys' thoughts are in terms of being able to do your jobs and have a safer community if we could catch people a little bit earlier and find them help, people that their health is degrading, they're just getting worse, or they have a history of getting worse. So what your thoughts are, if you guys could change the civil commitment laws, what would you do? Thanks.
Fantastic question. Thank you, Tim.
I know we're at time. My name is Debbie.
Hang on, because they were going to actually respond to that question.
Let me give
the
number of catch-22s that you just illuminated there with that story, that in our system of care that goes across different modalities, medical, psychiatric, correctional, judicial, there can be a competitive denial of responsibility where the psychiatric people say, oh, no, this is a medical condition. He's got a traumatic brain injury. And the medical folks say, oh, yeah, but that traumatic brain injury is stable. He had a pre-existing condition of schizophrenia, and all this other stuff is secondary to that. And, that's a tug of war about who doesn't get to win and end up stuck providing that person care. To answer specifically your question, if the idea that it can be removed, that third-party support that's keeping that person from being gravely disabled can be changed so that it recognizes that there should be a public safety net in place for people who require a higher level of care versus depending on families who are sometimes stretched past their ability to bear it to provide support for that person. That would be a compassionate change to the law that would enable the psychiatric system of care, at least mental health system of care, to provide help to people who otherwise are able to be unable to access voluntary treatment and are relying on their family to keep them safe to something that often has these kind of really traumatic ends that you talk about. So that would be a positive change. And of course, that's something that needs to happen at the state level, and our local systems would adapt to that.
I do have some concerns with taking away people's rights. I mean, if you're going to be advocating for expanding grave disability, you're going to have more people that don't get the ability to speak for themselves. And since that's kind of what the public defender does in these hearings, we're going to have more people that feel that they're trapped in the system, being forced medication, being forced to stay in SV, being forced conservatorship. And right now there's close calls. We go to trial once a week, weekly, sometimes 2 a week, that either the person feels that they should not be on conservatorship or that we as public defenders, don't necessarily agree with the doctors that they should be on conservatorship. So if we're expanding that, we're going to get a bigger pool, and some people are going to be put on conservatorship or put in SV that maybe don't need to be. So I think we need to be conscious of that as well. So there are two sides of that issue.
Totally agreed, as you know, right? That we're really fortunate to have the check and balance of the public defender who is there to advocate for the self-determination of folks who in the old days, they were sent to the state hospital and they were locked up, and they could be locked up from the time they were teenagers until they passed away decades later, because they did not have that right to self-advocate, and they weren't able to get a public defender to say, I have rights like everybody. So there's checks and balances, and it's a constant tension between the two. I appreciate and respect our public defenders here in Humboldt County, because I recognize that, we're not always 100% right. We have our biases as well. We want to predict that something bad is going to happen, even if we don't know for sure that it will. We want to keep people safe, but people get to say, "Hey, I get to take my chances. I think I can take care of myself." And sometimes they prevail, and sometimes we prevail. So there's a check and a balance to that system. But I recognize the position that it puts families in when they're told that, based upon our rules, we have to wait for this person to get worse before we can help them. Who wants to hear that? Nobody. So if positive change can be made for that, our systems will be able to adapt to it.
Yeah, we recently had one of our clientele passed away back in mid-February. Was hit by a car. Months later, passed away. And myself, Laura, and Officer Clark were in the hospital, room with them with a friend. It was kind of weird, seeing an individual that we had lots of contact with. We were arrested. We've placed on hold before. We engaged them daily. His behavior was often unacceptable, but yet we still connected with him. And so here we are sitting in this room, this person who's going to pass away in a couple of days. We know it's going to happen. And, my thought process was, how do we come to this point where I can't remember how old, I think in early 30s, how do we come to the point where this individual obviously had his extremely traumatic childhood, to where he's an adult being homeless on the streets, and he is extremely psychotic often. His behavior, it's obvious in desistance, and here we have a system in place that didn't work for him. And we look at it saying, what piece of the puzzle, at what point in time could we have intervened to stop this tragedy from happening? Because things, especially with our folks that have a tragic death, not only the only victim involved there, you have other people that are also traumatized by it. And so when we looked at issues like this, although I'm not in favor of pulling people's freedom away, I also don't want to create more victims. I want to minimize the trauma in the community, and I also want people to have a good life and be alive. And so it's just one of those things where, what can we have done since a child who had severe trauma all the way to an adult who was on the street, should have been medicated, probably should have been conserved, and here he is just roaming the streets, getting hit by vehicles, getting in fights. And I just, there has to be something in place we can intercept people before this happens, and that's my view on it, while balancing people's rights to live freely.
Thank you. Leah, did you have any comment on any of that?
Boy, I have a lot of comments, but I'm not going to keep everybody. But it's so painful for a family member to watch their loved one escalate into psychosis, and knowing the end might be death. We know that the end could be death. And that's the thing that causes families, I think, to want somebody to get involuntarily treated. And oftentimes it only takes, in the case of my son, 4 days. He gets help. He gets on his meds. He's good to go for a while. It's not like, he's going to be conserved or his rights taken away for a long time, but it saves his life. I often think of animals, and if you see a dog in the street that's going to be hit by a car, animal lover, get the dog, take care of the dog, find the dog an owner, take the dog to a shelter. I sometimes, and I don't want to upset the animal rights lady in the audience, but sometimes I feel we care more for our animals maybe than we do for our fellow human beings, but I don't want to get off on that soapbox. But before we end, I just want to read 10 principles of support. Should I do it now, Jacob?
I think we had one more
Okay,
comment
let's
that
let
just
Deb-
wanted
oh,
to
yeah,
say their
poor Debbie's
appreciation.
waiting, and then I wanna turn
And
it-
then we'll close out.
Okay.
Yeah.
And I have just a question here I'll put there too. My name is Debbie, and I wanted to recognize DJ Jaffe, who was talking about people who are dying with their rights on. He passed away a couple of years ago, but through the Treatment Advocacy Center, which is a national program, we can find out a lot about the laws and how to change them. I made a lot of notes before I came. A lot of what I was writing about was talked about, and I'm so glad because I thought that I was going to have to bite my tongue. I'm so happy to be in a safe place. What I do want to say is there was years ago, I don't know how many it was, but I believe Marion Pennicamp was one of the people that mentored me and brought us all together in a safe place. And it is amazing to me to see that this conversation is still happening in a new direction. It started as people being very conscientious about what they were going to say out loud in a public space. And how long ago was that, Tim? When did we do that at the Congregational on Hodgson? It was a long time ago. I want to say 10, 15 years ago. In Miriam Pennicamp's honor, I want to say thank you very much for this opportunity to hear from our community and to be heard. And I gave all of the suggestions that I heard come out of people's mouths onto those cards and gave them to you. And if you have any questions, you can reach me at any time. And NAMI, I think, is going to be where this volunteer task force is going to come in, because we need the help at NAMI to do the family to family. And I think that could be the place where we can really make things happen that we've talked about here today. Thank you.
Thank you. And in checking in with our wonderful and amazing social media manager too, we will do our best to answer a lot of those questions that did not get asked today on the note cards, and we'll try and get some answers to those and then pull those out on social media. So keep an eye out for that. Thank you everyone for coming. I'd like to just kind of kick to the panel for any like closing thoughts or statements or anything like that. We really appreciate you coming. And
so I just wanted to, we end our support groups with 10 principles of support. And I thought it would be very helpful just to read them quickly to you guys. And so the first one is, we will see the individual first, not the illness. Number 2 is, we recognize that mental illnesses are brain disorders. Number 3, we aim for better coping skills. And the 4th one is, and this is really important, I think, we find strength in sharing experiences. We reject stigma in ourselves and others. We won't judge anyone's pain as less than our own. Number 7 is, we forgive ourselves and reject guilt. 8, we embrace humor as healthy. I have a lot of funny stories. I won't share them right now. And 9, we accept we cannot resolve all problems. 10, we expect a better future in a realistic way. And then our whole group always says at the end, we will never give up hope. Thanks.
thank you, Leah. Any other last comments or thoughts?
Can I just say that I really feel deeply when we have these issues of loss in our community. They affect everybody. And I hear loud and clear from people who have the request that we do better. And on behalf of the agency I work for, DHHS, all the people I work with, I know that we try to do the best we can. And I recognize in talking with some folks here today and elsewhere that there are problems that are really, really hard to solve. And some of them are beyond our grasp right now. But we have a lot going for us as a community. There are real strengths here. There are wonderful people in our community. And we're able to collaborate. We have a really nice scale here, actually, where when it requires a multi-agency response, we're able to reach out and we're able to connect, and we have long-term relationships with people. So there are really positive, good things going on. And even though we still have problems, and even though we still have loss that we all feel really deeply, we're here together for one another. And that's why we do this. So I appreciate what all of you overcame to come here today and to provide us with the opportunity to hear from you. It really matters, and I just want to thank you for that.
If I could, I just wanted to say, Kim knows very well.
Hang on, Stephen.
And,
Can you and I talk afterward? Because we're already past
time. I just wanted to thank everyone for coming, and I wanted to say I got a lot more out of this than I expected. It's been a real pleasure, and I just wanted to thank everybody. This woman and this woman especially made very good points, and I just wanted to say this turned out a lot better than I expected.
Well, thank you. I'm happy to hear that. That's fantastic news.
Last thing, I'm proud to work for an agency that for Eureka Police Department has allowed us to progress our programs and expand to the rest of the city. Proud the city has programs, Uplift, brought Care on board. We're not saying they're perfect. We're not saying they're going to solve the world's problems. But when I look back, when I became a law enforcement officer back in 2007, is this what I thought I'd be doing, talking about? Absolutely not. But this is really, there's so much overlap nowadays with mental health, law enforcement. This is really where the work is needed in many ways. It's important work for us, for law enforcement, to make sure we're doing things correctly. We're building programs that are going to alleviate work from law enforcement officers, but also recognize that, hey, sometimes we actually need a law enforcement officer there with a clinician or with a case manager, making those human connections with folks. So when people are ready to go to rehab, or if they're ready to go to housing, or if they're ready to do whatever they want to do, go back home to family, we're able to connect the dots quickly, strike when the iron's hot, and also have the resources to do so. So it's been a very awesome experience the past 5 years, and I'm looking forward to where our programs are moving forward. And I think our good things are on the horizon. And when we look at other cities, we talk to cities across the country with programs similar to CSET, Care and Uplift, and a little city of Eureka is doing pretty good compared to many big cities. Again, it's not perfect. There's a lot of work to do. I could have a 30-slide PowerPoint about the challenges we face. But the work being done here is very dedicated people to do the work that has to get done. So thank you.
Thank you.
Yeah, I just want to say thank you for this. The issues that I see in the courts are more with funding. We just don't have the right programs for people. We let people out of jail with nothing, tell them to go to mental health. They don't know how to get there. We need people to meet them on the street as soon as they get out, tell them what to do, show them where to go, ask them what they need. And right now we just don't have it. My office and conflict counsel each have one social worker, but we have hundreds and hundreds of clients. We can't serve them all. So from my perspective, it's a funding issue, but that's something we can work on. And we've got it started. It's getting better. If we just continue to work on it, I think it'll get better.
Thank you. I'd like to thank everyone for coming out, and super appreciate you taking your time on a Saturday to come out and participate and really advocate for the community and come together and collaborate and bring solutions and ideas. It's super important. Remember, this is only the first of the series. We'll be doing this every quarter for quite some time, and are looking forward to continuing that collaboration and kind of solution finding going forward. I'd like to give a shout out and thank you to Eureka Police Department for their participation and innovations in mental health, especially the officers that are outside as well, who are just as much a part of this as anyone else. I'd also like to give another shout out to Humboldt County Behavioral Health for lending us Dr. Lammers today and his infinite knowledge. And just being such great collaborators and partners too, and really, supporting the city and working together and kind of moving things in the right direction. Thank you to the Public Defender's Office and NAMI as well for joining us. It's really amazing to see so many different parts of the field coming together and collaborating to really work on making our community better. Because that's really what it is about, right? We're all members of the community, and we can all come together and work on making it better for everybody. For the last closing remarks, I'd like to hand things over to Mayor Burgell. Thank you.
Hi, friends. So I just wanted to thank you all for being here. This has been a really important and robust conversation, and I hope that we can continue to move forward, working together to make positive solutions. I'll say it before we go. Every person in our community, every person has value, everyone. Sometimes it's hard to see, and it's a challenge, but everyone does. And I appreciate so much the direction that our city has taken, that the county is taking in this collaboration. And I also wanted to just say that I'm also really grateful that we've had some officials in the room. We've had Supervisor Natalie Arroyo is here. We've had Councilmember Scott Bauer, Councilmember Leslie Castellano, Councilmember Mario Fernandez, and city staff that are here listening and really hearing what you have to say, because it's important. It's important. A healthy community lifts each other up. Our next meeting potentially looks like June 3rd. We look forward to seeing you all there. Please reach out if you have any further questions or concerns. We're here to work together, right? That's a healthy community. So thanks again. Happy Saturday, and have a great weekend. Sorry we went late, but it was just so awesome. We couldn't resist.